Okay. So we'll start. Okay. Okay. So there are 6 mentees for today. Okay. Then so you don't have a copy of the learning objectives. I'll just show you the learning objectives as presented to us by the course coordinator. So given the patient, the mentees provide the details, clinical data clearly and concisely. So as much as possible, be relevant. Okay. Concise and relevant. Okay. That's why I gave you a patient management process now, which tend to come out with more concise discussions. Then number 2, provide a good history and present complete physical examination as one would proceed in a bedside preceptorial or as one would proceed in a clinic consultation. So in a clinic consultation, usually it's a short interaction with the patient, usually 15 or sometimes 20, okay, but not as long as 30 minutes, okay. So usually 15 to 20 minutes now. So that's why you have to be relevant in your history taking and also your complete physical examination. When I say complete, it will be those which have pertinent positive, pertinent negatives only, okay? And then number 3, give the differential diagnosis and explain how the group arrived at the primary working diagnosis, okay? So when you say primary, it's the first one. Secondary is the second one, okay? So you don't have to give a list of 10 differential diagnoses. No? So that goes for efficiency. Then explain the pathophysiology of the disease at hand and may include theoretical data or possible existing epidemiology of it, okay? So relevant discussion on that. And then provide options for additional diagnostic maneuvers or studies. Okay, I think this is in red because I just added this one because it's missing on in your syllabus. Okay, so you must be able to provide options for needed additional diagnostic procedures, which I call paraclinical diagnostic test. And then provide the surgical plan or even the medical plan if indicated and other treatment options. Then present a journal appraisal with relevant clinical questions regarding the management of the patient. Okay. So is everything clear about the learning objectives? So this is the starting point of our discussions. Okay. Then so Nicole gave me a copy of how I'm going to evaluate you. So history, physical examination, differential diagnosis, diagnostics, treatment plan, relevant journal, psychosocial concern, questions and answers, communication skills, presentation. Okay. So here I will base my evaluation on your participation in the class in this particular Zoom. Okay. Okay. So basically, it's the same history and physical examination, primary working diagnosis, differentials, plan of management in terms of diagnostic, and then therapeutics, especially surgery, then complications, post prognosis, and surveillance. Okay. So criteria for journal appraisal, the research question based on the clinical problems related to the management of the case, which you were able to identify, description on how the article was sought, then summary of the journal, 5 points, and then journal appraisal based on a checklist. No? Okay. Okay. Now, I'd like to inform you that the grading here will be individual, okay, mainly through group participation, okay. So when you say group individual participation, active participation through answering questions, that I might throw to any one of you, and then you can ask questions to me. Okay, so I like to expect at least two questions per mentees. Okay, And then I will also consider the contribution to the case report and journal appraisal. So Nicole, you have to write down the contribution of each of your members. No? Okay. And then submit them as soon as possible. Then, okay, how you're going to grade me? Okay. So I take note of that also so that I can be guided. So explain the objectives, expectations, and various requirements of the course, which I did now. Okay, I just did it a few seconds ago. Encourages students to think critically and collectively, communicates clearly, answer students' questions clearly and adequately, is able to help students understand complex ideas related to the subject matter, uses engaging and helpful learning exercises and activities, relates the subject matter to issues and developments in the disciplines and real-life concerns. So I have to add some of this extra discussions on this. Encourages students to participate in the discussions and these activities. Make himself available for consultation. Okay, I don't know how I'm going to do this because of the COVID. Okay, I'm not there all the time. So, but I'll try to make up by giving you my Facebook account and also my email so you can consult me anytime. Encourages students to express their ideas and viewpoints, communicates, interacts with students in a positive way, show respect for students' diversity and individual differences. Okay, you came from different schools and you have different background. Okay, makes full use of the required hours of the learning. Okay, so I allotted up to 12:30. I hope we can finish earlier. Provides fair and timely feedback on students' performance, and then uses clear criteria to evaluate the students' performance, which I have shown to you the evaluation sheet. Okay, everything's clear? Okay, I think, okay, there's some addition there in relation to the learning experience in this class. What does your teacher do that you find very helpful and effective? How do you think teaching this class can be improved to enhance your learning experience? How can the teacher utilize technology more efficiently to enhance your learning? Okay, this was added here because of the pandemic. Okay. Okay. So as I said, I'm going to make myself available for consultation. You can add, message me or friend me in my Facebook. Okay, so these are my two accounts, then my email, my cell phone number, and then lastly, okay, so I have extended my contribution to the teaching by showing you a video on this patient management process and overview. And then later on, at the end of the class, you will have to answer this so-called OLETE. OSIL means Online Collaborative Interactive Learning. OLETE means Online Learning Cum Evaluation Test Exercise on Patient Management Process. It's an objective type of questions. You just answer it. If you don't get the perfect score, you just repeat it until you get the perfect score. So this is the link. I'll give the link later on in the chat box again. Okay. So try to have a perfect score to reinforce your learning on the patient management process. I know this is the first time that you are encountering this kind of teaching on patient management process. So I saw some weaknesses in your report, but we will try to remedy that through the discussion and also through this OLETE, OSIL Online Learning Objectives. Okay. So any questions? Everything's clear? Show your hands. Okay. Clear? Okay. Okay, what? Sige. You will present now the, I usually start with the journal appraisal, but this time, because I've not read completely your report, it came late last night. I was sleeping already at 11:30. Okay, so we'll just go through the whole process, that journal case presentation first, and then journal report. Okay, so just remind me. Probably will allot about 20 minutes for the journal report. Okay, The reason why I would start with the journal report because there'll be extensive discussion on the case presentation. No? Okay. So I might forget the journal report. So remind me at exactly 12 or even earlier. No? Okay. 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 Now it's your show now. Who's going to start?
Good morning po, sir. So our case discussion for this morning is on a case of anterior neck mass. So this case will be presented by members of Block L po.
Okay. Good morning, sir. I'm Ira po. And I'm going to present the case.
Okay.
Next. So this is EDN, a 53-year-old male, former factory worker, high school graduate, living with his wife and 2 adult children at Caridad, Cavite. He has no known comorbidities and no previous hospitalizations or surgeries. So he came in with a chief complaint of enlarging neck mass. Next slide. This neck mass was first noticed 2 years ago, where the patient said na he felt a marble-sized lump at his left neck with no associated hyper or hypothyroid symptoms, no pain, no signs of infection, and no obstructive symptoms. At this time, patient sought consult with a private physician and some workup was done, but the patient has no copy of the results. But the patient was told to regularly follow up every 6 months for an ultrasound. But due to COVID restrictions, once lang daw po siya nakapunta for a checkup. And then after that, 2020 na po kasi, he wasn't able to comply with the follow-ups. In the interim, this patient noted gradual enlargement of the neck mass, still with no associated symptoms. So no hoarseness, no dysphagia, no adenophagia, no stridor, no palpitations, no heat or cold intolerance, no lethargy, and no weight loss. However, the persistence of the mass alarmed the patient. So in October of last year, he sought consult at GS1 clinic, where he was told to undergo FNA, and then it was done, and his histopath results came back as CAT1 non-diagnostic with hemorrhagic aspirate smears. This January, he came back for a follow-up, and this patient was advised to have surgical removal and biopsy. Next slide. So for the ancillary history, past medical history niya po, unremarkable, no previous hospitalizations and surgeries. For the family medical history, only pertinent for hypertension. For the personal social history, only risk factor only risk factor here is yung 19-pack year smoking history niya and occasional alcoholic beverage drinker po siya.
As for the pre-operational findings po, physical examination findings, so the patient was awake, conscious and coherent and not in cardiorespiratory distress. He had stable vital signs. For the HEENT examination, he had anicteric scleraping palpebral conjunctiva. Upon examination of the neck, he had 3 by 3 centimeter firm nodular left anterior neck mass that is non-tender and it moves with deglutition. However, upon looking for cervical lymphadenopathies, there are none. And also, he had flat neck veins and there's negative for Pemberton sign po. As for the other findings, they are all unremarkable po. So for the chest and lung, symmetric chest expansion, clear breath sounds, no crackles, no wheezes, no retractions. For the abdomen, for chest, there's a dynamic precordium, normal rate, regular rhythm, distinct S1, S2, no murmurs appreciated. For abdomen, it was flabby, soft, Umbilicus midline, no visible masses seen, discoloration or pulsation. As for the extremities, no edema, full equal pulses, warm extremities, and CRT less than 2 seconds. Next slide. So this was a picture of the patient's neck. So it wasn't actually apparent, the mass wasn't actually apparent of visual inspections. So, next slide.
So moving on po to the case management and discussion for this case. So first, starting po sir with the clinical diagnosis. So we have a case summary for our patient. So we have EDN, a 53-year-old male, 19-pack-year smoker, clinically euthyroid with no known comorbidities, presenting with a 2-year history of a gradually enlarging anterior neck mass with no associated dysphagia, hoarseness, dyspnea, or weight loss. So no signs of obstructive symptoms or metastatic symptoms, with no history of neck irradiation or family history of thyroid cancer. So on physical examination, this patient had a 3x3 centimeter firm, nodular, non-tender anterior neck mass that moves with deglutition. There was no noted cervical lymphadenopathy. So the diagram in the slide shows kind of the summary of the clinical presentation of the patient with the patient profile as well as associated signs and symptoms. So this slide shows sir our kind of approach in coming up with our primary and secondary clinical diagnosis for our patient based on pattern recognition as well as any prevalence data that we can find. So our primary diagnosis for this case is multinodular non-toxic goiter, and our secondary clinical diagnosis is well-differentiated thyroid cancer. So starting with our primary clinical diagnosis, which is multinodular non-toxic goiter. So just a brief background and pathophysiology. So kapag sinasabing non-toxic goiter, it's basically thyroid enlargement but with no disturbances in thyroid function. And we say this kasi parang wala namang hyperthyroid or hypothyroid symptoms si patient, wala siyang any cold or heat intolerance, diarrhea, constipation, tachycardia, and the likes. So the risk factors for this disease include female, increasing age, as well as low socioeconomic status. And the pathophysiology in general for goiter is, the most common is yung iodine deficiency pa rin, which is yung component kasi ng thyroid hormones natin. When there is decreased iodine, there is parang this positive feedback loop sa pituitary gland natin, causing production of TSH, which stimulates our thyroid gland. But specifically, yung pathophysiology for yung multinodular non-toxic goiter is parang polyclonal po yung origin ng mga cells. So parang maraming nodules. So iba-iba yung origin ng mga sites nila. And this is induced by yung mga growth factors natin, mga cytokines, causing hyperplasia of our cells. So yun, next slide. So for the clinical presentation of this disease, pwede siyang asymptomatic, especially yung mga nodules na less than 1 centimeter. So usually kapag ganun, hindi pa siya napapalpate, or pwedeng incidental finding then based on mga imaging studies for our patient. However, yung parang classic clinical presentation is central neck swelling or anterior neck mass that is nodular, and this mass moves with deglutition. So yun yung parang sign na alam natin it's the thyroid. It's like thyroid in origin yung mass. So, however, kapag medyo nagiging malaki na rin kasi yung mass, it may cause subsequent signs and symptoms sa patient natin. So, pwedeng yung mga obstructive symptoms, such as yung dyspnea, nagko-compress sa trachea, so nahihirapan huminga si patient, or nagko-compress sa esophagus, so nahihirapan siya lumunok, so dysphagia. And then, pwede rin siyang mag-compress sa recurrent laryngeal nerve natin, which causes symptoms of hoarseness, although more indicative of more malignant causes if a patient presents with hoarseness. So, ayun, if malaki din yung mass natin, pwedeng ay nagkakaroon din ng tracheal deviation, pwedeng right or left. And then yung na-mention din ni April earlier na Pemberton sign, which is when you ask the patient to raise both his arms, nagkakaroon siya ng facial flushing, and this is indicative of increased pressure dun sa thoracic inlet. Lastly, notable na walang cervical lymphadenopathy dapat na present if we suspect more benign causes of thyroid masses. So our second clinical diagnosis, sir, is well-differentiated thyroid cancer. And again, the risk factors for this disease is females with a family history of thyroid cancer as well as radiation exposure in childhood, or pwede rin mga whole body irradiation, ganun. Tapos, just a short parang pathology background. Kapag differentiated thyroid cancer, usually yung origin ng mga cells natin is yung thyroid follicular cells. And then, if it's found in pathology naman na yung medullary thyroid, the patient, for example, has medullary thyroid carcinoma, yung origin ng mga cells is yung parafollicular C cells natin. So, based on on prevalence, pinakamarami pa rin talaga yung mga well-differentiated thyroid cancers natin, which include either papillary or follicular thyroid cancer. So, naka-indicate naman sa slides yung mga percentages nila. Almost 90 to 95% yung well-differentiated, and then less than 5% na yung mga other types na more malignant, such as yung mga medullary thyroid carcinoma as well as yung anaplastic thyroid carcinoma. Also, if it is found na, for example, parang we suspect nga na may well-differentiated thyroid, mas more likely pa rin yung histologic subtype na papillary versus follicular. Next slide. Okay. So, for the clinical presentation of thyroid cancers, almost similar clinical presentation siya na meron kang anterior neck mass. However, meron lang mga notable signs and symptoms that you would have to note that would make you suspect more malignant yung condition na meron yung patient. Such as, for example, parang suddenly, mabilis lumaki yung size ng thyroid or ng nodule. Or again, may family history yung patient ng thyroid cancer, may past history ng neck irradiation. And syempre din yung mga metastatic signs and symptoms natin, such as yung cervical lymphadenopathy, mga hoarseness, which indicate invasion sa mga adjacent structures. However, parang important pa rin i-note na pwede ring absent to mga symptoms na to kahit na may cancer yung patient, kasi what if parang early stage na thyroid cancer pa lang siya. So, if papalpate mo rin yung mass, it's most of the time firm, immobile, and immobile siya. So, yun. This is just, again, yung slide earlier, which summarizes our approach to our clinical diagnosis po. However, di ko pa na-discuss yung prevalence. So, according to up-to-date by ROS 2022, in all thyroid nodules, there is a 4 to 6.5% risk of thyroid malignancy. So, medyo mababa lang yung percentage niya. And also, if you consult other references, I've also read sa StatPearls na yung estimate naman nila doon is around 5 to 10% of thyroid nodules are because of thyroid carcinoma. So parang around that range lang siya. Medyo mababa yung percentage niya, prevalence-wise. And this is the reason why we more considered po more benign causes of the nodule, such as a multinodular non-toxic goiter as compared to a well-differentiated thyroid cancer. However, we still included yung thyroid cancer as our second diagnosis, given yung consequences if na-miss tong diagnosis na to. So, although mababa lang yung mortality rate ng mga thyroid cancers natin, parang risky pa rin na ma-misdiagnosing patients with more benign causes. That's why workup is important po.
Good morning po, sir. I'm Kate po. I will be discussing about the paraclinical diagnostic procedures po.
Okay.
So first po, I will first restate po our clinical diagnosis. So next slide, please. Okay, so our primary clinical diagnosis, as discussed by Anne, is multinodular non-toxic goiter. And our secondary clinical diagnosis is well-differentiated thyroid malignancy. So based on this clinical diagnosis po, a paraclinical diagnostic procedure should be done to eliminate the possibility of a malignant lesion, since the degree of certainty rin po on both the primary and secondary clinical diagnosis is not that high as well. So once proven to have low risk of malignancy, we may opt for a more conservative management approach for the patient. But if there's a high chance po of malignancy, a surgical approach po will be considered instead. Hence, a paraclinical diagnostic procedure will help, and it is important in this setting since different treatment plans po are indicated in each diagnosis. So, next slide, please. Sorry. So ideally po, so this is the ideal algorithm that is followed po for evaluation of a thyroid nodule. So many tests po are required in this algorithm. So in this algorithm, nakalagay po na we must first request for an initial test of TSH, and then once may result na yon, tsaka tayo decide what procedure po yung next na i-request. Pero in our setting po in the Philippines, this is not really practical po for the patient then. So we must choose lang po tests that are really that will really help in ruling out or considering our primary and secondary clinical diagnosis. So for the next slide po, I will be presenting options po for the patient along with the BRCA po, the benefit, risk, cost, and availability. Apologies po, sir, if I didn't include this po in the paper that was submitted po. I just added this po last night po. Sorry.
Okay.
Okay. So for first po, TSH testing po is a laboratory test po. So usually po, this is the initial test po that must be requested in the evaluation of a thyroid nodule po. So it has a sensitivity of 61% and specificity of 65%. So ito pong benefit that I searched about with these different procedures po, this is in the setting po of predicting thyroid malignancy, since we're trying to eliminate the risk of malignancy in our patient. So yung TSH po, yung sensitivity and specificity niya po for thyroid malignancy is quite low po. Pero ideally po, this should be the initial test, and then if pag yung result po nito ay normal or high, dun tayo proceed with FNAB or biopsy. And then kapag naman po low yung result ng TSH, we will proceed po with RAI scan. So this is naman po widely available in all hospitals and in PGH din po. And the cost is around 500 pesos po. For the imaging modalities naman po, I provided po 3 options po for the patient. So we have thyroid ultrasound with a sensitivity of and specificity of 95 to 100% in predicting thyroid malignancy. No risk naman po or acceptable naman po if meron. And then yung cost po niya is 800 to 1,000 pesos po, and available rin po siya sa PGH. Then we have po CT scan and MRI, although ito pong CT scan and MRI po kasi lower sensitivity po and specificity than ultrasound in predicting thyroid malignancy. So this is more useful po for evaluating extrathyroidal tumor extension or yung extent po ng thyroid malignancy, or more useful rin po siya kapag large na po yung goiter and kapag po merong mga metastasis. So acceptable rin po yung risk niya, and it costs around 2,000 to 5,000 po, and available rin po siya sa PGH. And then we have po PET scan, positron emission tomogram scan. So ito po used to screen malignancies naman po when other imaging studies are already negative. So parang ito na po yung last option kapag negative na po yung ibang imaging modalities. Pero this is quite expensive po. So, as I've searched po sa different hospitals, parang sa NKTI po available po siya, Cardinal and St. Luke's, pero more than 30,000 to 50,000 po yung price niya. There are some risks po, pero acceptable naman din po because the benefit will outweigh rin po the risk. And then for the most important test po or is the histopathology or the biopsy. So the fine needle aspiration biopsy po, it has a diagnostic accuracy of 97%. So it is said to be the single most important test po in the evaluation of thyroid nodules since ito po yung makikita niyo po talaga kung malignant siya or benign based on the histopathologic findings po. Although meron po kasing mga samples na nag-yield ng non-diagnostic or kapag yung specimen po ay hindi adequate. So yun po. So dito po the fine needle aspiration biopsy, it may be done po with or without ultrasound guidance. And then ito po medyo invasive po siya pero acceptable naman din po yung risk since the benefit will still outweigh po the risk. So it costs around 500 po and available din po siya sa PGA. So for this patient po, our test of choice po is for the imaging modalities is thyroid ultrasound po since the sensitivity and specificity is high along with the low cost po for the patient and readily available din po. So next slide po. So for the actual results of the patient po, so actually 3 tests po were done for our patient. We have the neck ultrasound, the thyroid function test, and the fine needle aspiration biopsy po. So for the neck ultrasound, so this was the result po of the patient done last November 5, 2022. So the thyroid is enlarged with heterogeneous echo texture. It exhibits normal parenchymal vascularity upon color Doppler. Several lesions are seen in the right lobe that are mixed, cystic, and solid, hypoechoic, wider than tall, and smooth margin and non-calcific. While on the left lobe naman po, it exhibits vascularity upon color Doppler interrogation, and there are several macrocalcifications po occupying almost the entirety of the left lobe po. So the impression for this was multinodular goiter with a thyroid score of thyroids 4, which is moderately suspicious for malignancy. And the recommendation is to perform a fine needle aspiration biopsy since the size of the nodule rin po is greater than 1.5 centimeters and then correlate with the thyroid function test results. So as mentioned po, the patient was TR4 or thyroids 4 po scoring. So this can predict po the possibility of malignancy. So according po dun sa thyroid scoring, if the patient has moderately suspicious ultrasound findings po, this has a risk of malignancy of 9% po, 9.1%. So yung sa thyroid scoring po, 5 ultrasound features are used. So it is based on the composition, echogenicity, shape, margin, and punctate echogenic foci. So each item is given points and the points are added from all categories to determine the thyroid score. So and each thyroid score po has recommendation. So for this one po, for thyroid score, ang recommendation po is to perform a fine needle aspiration biopsy. So next slide po. So for the thyroid function test of the patient, so as we can see here, the serum TSH of the patient is low po. So serum TSH po is important and should be obtained upon discovery of a thyroid nodule greater than 1 centimeter in diameter. So for the reading po of this, since the patient has low TSH with normal thyroid hormone levels, the patient po has subclinical hyperthyroidism po. So according to the guidelines for subnormal TSH results, ideally a thyroid scan should be performed to determine whether the nodule is hyperfunctioning, isofunctioning, or non-functioning. Tapos, each of those po has its own risk of malignancy, percent risk of malignancy po. So this will also dictate the need for cytologic evaluation. So yun po, for our patient, his serum TSH is low, indicating that he has an overactive thyroid or hyperthyroidism. So some studies have shown din po that low TSH levels increase the risk of papillary thyroid cancer. Next slide, please. So, sorry, next slide po. Yung sa fine needle aspiration biopsy, sorry. Result. Yan. Okay, so for the fine needle aspiration biopsy result, 4 slides po were submitted to histopath. Unfortunately, the slides po were non-diagnostic. So they received po hemorrhagic aspirate smear. So from the Bethesda system for reporting thyroid cytopathology po, this was under category 1 or non-diagnostic, and the recommendation should be to perform repeat biopsy. Pero in this case po, hindi po nakapag-perform po ng repeat biopsy for the patient po. Okay. Next slide na. Thank you.
Good morning po. Rinig po ba ako? Hello po, I'm Phil Garcia po, presenting the treatment for this patient. Next slide po. Yun po, for the pre-treatment diagnosis, the primary impression is multinodular toxic goiter, and the secondary impression is differentiated thyroid cancer po. Next slide po. For this po, I apologize po for going in a different direction po, kasi po supposedly primary po is yung treat. However, this patient came in with anxiety or fears of rapid aggressive enlargement of the kaya gusto niya na rin po mag-opera, and that he's also at the age na near risk na po siya, and may chance pa rin naman po na magkaroon ng cancer, and that non-diagnostic po kasi yung FNAB. So might as well po na commit na po sa well-differentiated po and do a surgical operation po. So for the goals of treatment, it is number 1 po is to prevent or minimize the risk of disease recurrence and metastatic spread. Number 2 is to increase the survival rate. Number 3 is minimize the risk of complications, adverse effects of treatment. And number 4 is to choose a treatment that is practical for the patient po. Next slide po. So for the choice, number 1 is total thyroidectomy, and 2 is lobectomy po. Next slide po. So for, since we're considering well-differentiated thyroid cancer po, since hindi naman po sobrang aggressive ng presentation, we'll consider papillary and follicular. So for papillary, the NCCN guideline for thyroid carcinoma 2022 recommends that in patients with PTC po, or suspicious for PTC with a nodule larger than 1 cm, and if all these criteria are present po, no prior radiation, no distant metastasis, no lateral cervical lymph node metastasis, no extrathyroidal extension, and tumor 1 to 4 centimeter in diameter, which present po sa all the patients, our choice could be total thyroidectomy or lobectomy. However, for this patient, meron din pong thyroids 3 and thyroid 0 na sa contralateral lobe. For this po, kino-consider the NCCN guidelines was not strict po on na mag-total thyroidectomy for those cancer with contralateral micro cancers po. Sabi lang po is to consider lang po na mag-total thyroidectomy. And number 2 po, next slide po. And the other consideration will be a follicular neoplasm. For this po, na no need po na if the patient presented with a Bethesda 4 po, ang primary treatment po will be thyroidectomy or lobectomy. So for this po, kaya po total thyroidectomy sa lobectomy po yung choices namin. Next slide po. So for the BRCA of, sorry po na may na-cut off po yung slide, pero this is for the BRCA of total thyroidectomy. So for this po, for the benefit po, for the survival rate, a retrospective study was done by Villamora and others po in 2005 comparing the survival and recurrence of total thyroidectomy and lobectomy na pool of 52,000 patients with PTC. In general po, 95.5% yung survival rate, 10-year survival rate in patients with tumor sizes 3 centimeters to 3.9 centimeters, which our patient belongs to. So yun po yung survival rate na in-expect natin. 3 to 3.9 centimeters is 98.4. In low-risk patients po, which our patient belongs po, ang 10-year, on another study, ang 10-year survival po is 89% with a pool of 3,863 low-risk PTC patients po. Ideally po, mas maganda po sana if nakahanap po ako ng study na napag-combine to. However, I was not able to yung low risk and same size nodules po. However, hindi po ako nakahanap ng ganun study. For the practicality po, it is able to remove the contralateral microscopic disease. It enables accurate serial postoperative thyroglobulin measurements at allows the use of radioactive iodine for remnant ablation po, if ever kailanganin po. And important for this patient po is it will provide less anxiety for the patient po. For the risk po, the risk of 10-year recurrence of the study is 7.7 in nodules, 2.1 to 4 centimeters. The risk of nodal metastasis in the 20-year risk of metastasis on one study is 6% in a pool of 1,468 patients. The risk of distant metastasis in the risk of 30-year distant metastasis in one study po is 3% po in a pool of 1,468 patients. It also has the risk of hypoparathyroidism. So in one study po, it is 18%. The risk of hypoparathyroidism is 18%, and 9% of these patients required calcium supplementation, while 2.3% of these patients po had hypocalcemia. The total patient pool po in this study is 1,054 po. There's also risk of vocal paralysis in total thyroidectomy. 9.5% of the patients presented with vocal paralysis po in a pool of 5,670 patients on one study. And there's also a very low risk of bilateral recurrent laryngeal nerve paralysis in one study po, 0.1%. However, the pool of patients was not specified for this po. For the cost po, for active PhilHealth members and qualified dependent, the PhilHealth will reimburse 31,000 pesos po for this, and in most public institutions po, it is free. However, in some private institution na nakita po namin it's around 21,000 po. For the availability, it is available in PGH and other level 1, level 2, level 3 public hospitals such as JRRMC, East Avenue Medical Center, etc. po. Next slide po. So for the benefit risk cost availability of lobectomy naman po, in the same study as yung kanina po, the survival rate in low risk patients po was the 10-year survival rate in low risk patient po presenting with a stage 1 cancer po was 91%. In patients naman po with 3 to 3.9 centimeter size nodules po, which our patient belongs to, the 10-year survival risk is 97.1% po. For the practicality, it mitigates the absolute need for lifelong thyroid hormone replacement naman po. For the risk po, the risk of recurrence po for patients stage 1 thyroid cancer po who underwent lobectomy, the 10-year risk of recurrence is 9.8%. In nodules naman po na 2.1 to 4 centimeters, yung hazard ratio niya po is 1.24 compared to total thyroidectomy. The risk of nodal metastasis po for stage 1 patients stage 1 thyroid cancer patients who underwent lobectomy po is the 20-year risk for nodal metastasis is 19%. And the risk of the 30-year risk of distant metastasis was 3%. For the practicality, which belongs to the risk, there is a higher chance of a secondary surgery for patients who that are stage 1 cancers po, who underwent lobectomy. It was found in low risk PTC patients with nodules ranging from 1 to 4 centimeters, 57.5% of the lobectomy patients will need to undergo a second operation po. For the cost po, same as above po na 31,000 will be reimbursed by the PhilHealth, and it is free in most public hospitals, while in some private hospitals, it costs less daw po compared to total thyroidectomy, which costs 21,000. This one po, lobectomy costs 16,000 po. For the availability, it's available in PGH and other level 1, 2, and 3 public hospitals, and public and private hospitals such as GRMC, ISAV Medical Center, and St. Luke's po. So for our choice of treatment, it will be next slide po. Yan po. So, sorry po, it was cut, pero yung second row po is total thyroidectomy. The third row po is non-significant. Yung fourth row po is lobectomy. So for the benefits po, so in summary po, the benefits for total thyroidectomy is number one, which is most important po, is it causes less anxiety for the patient po, and the practicality na pwede na po i-treat agad. Number two is significant po yung survival rate niya compared sa lobectomy in same size nodules. Number three is it removes contralateral microscopic disease. Other benefits na it's not as major as those first three po is it allows accurate serial postoperative thyroglobulin measurements and allows the use of RAI for remnant ablation if kung sakaling kailangan po. Survival rate in same risk patients was non-significant po in between total thyroidectomy and lobectomy. So for the benefits of lobectomy naman po, ang meron lang po siya is it mitigates the absolute need for lifelong thyroid hormone replacement po. So for the risk po of total thyroidectomy, it has the risk of hypocalcemia and calcium supplementation. It also has a risk of vocal fold paralysis, and it also has a risk of bilateral recurrent laryngeal nerve paralysis. However, this risk is very low and is more common in higher stage tumor. So ang major lang po talagang risk for total thyroidectomy is the risk of hypocalcemia and calcium supplementation and vocal fold paralysis. For lobectomy po, ang risk niya po is the 10-year recurrence rate in same size nodules is significantly higher in lobectomy, and the 20-year nodal metastasis of lobectomy is significantly higher than total po. The risk of distant metastasis was not found to be significant, and there is also a higher chance of having a second surgery. For the cost po, it is about the same po. It depends on which institution the patient will have the operation. Pero on private po, the total thyroidectomy costs a little bit more po. And for the availability, it has the same availability. So for this po, we choose total thyroidectomy since number one po, since it provides since yun na rin po talaga yung gusto ni patient po talaga. Yun po. Thank you. Next slide po. So for the treatment procedure done, total thyroidectomy was done last January 16, 2023 at PGH RCB 15 for a duration of 3.5 hours with an estimated blood loss of 100 ml. Intraoperatively, a 3 by 3 centimeter firm encapsulated mass was on the left lobe, and a subcentimeter cystic nodules on the right lobe was identified. Sorry, yung final diagnosis po, this was not the histological diagnosis po. Pala, sorry po. This is not yet for the diagnosis, the histopath po. Next slide po. Ito po yung specimen na nakita, sir. For the post-operative outcomes, on day 1 po, there was no on post-operative day 1, there was no subjective complaints such as palpitations, weakness, numbness of perioral or extremities, hoarseness, carpopedal spasms, difficulty swallowing, dysphagia, difficulty of breathing, and the patient had adequate control. On PE po, he was comfortable and not in distress with stable vitals. There was noted dry bandage on the anterior neck. The Penrose drain was removed after 1 day. There was no noted hematoma. The wound was well opposed. There was no bleeding, no Kopf's sign. For the medications, he was given pain meds such as celecoxib, paracetamol, and tramadol as needed. He was immediately started on levothyroxine 100 micrograms per tab, 1 tab prior to breakfast, and calcium carbonate 3 times a day, and calcitriol 1 tab a day. There was noted when that the 24-hour post of corrected calcium was low at 1.9 po, which was corrected with calcium gluconate trip. The patient was sent home after on post of day 3, stable with clearance po from endo and gen med po. Next slide po. Thank you.
So moving on towards the health prevention of health promotion for this patient. To reiterate the final diagnosis, since we still don't have a final, the histopath is still multinodular non-toxic goiter to consider well-differentiated thyroid cancer. Status post total thyroidectomy last January 16 in PGH. So when we're looking at the patient framework based on the framework developed by Dr. ROJoson, we look at first the task of the physician in establishing all of these things from the start until the end of, from the initial contact with the patient until the very end. So step by step, when we're going through the clinical diagnostic process as well as the paraclinical diagnostic process, through the treatment process, and then finally when we're monitoring the patient. And throughout all this, we have to establish that we maintain the goals of the patient, and they're also aware of these goals, such as we want to prevent complications and disability, we want to maintain patient satisfaction, and we don't want a medical legal suit with this. Also, throughout this, we want to maintain quality standards that are rational, efficient, effective, and humane for this patient. So when we're coming out with identifying the goals for patient management, it's important that we involve not just the patient, but also their family. So it's made clear and reaffirmed, and they're also part of the process of identifying what diagnostics to order, what the treatment is. Through this process, we should be able to establish rapport. So here is the management of patient framework as developed and given to us by Dr. ROJoson. So this is the patient framework made specifically for a patient. So from the interview, we were able to identify the patient profile, a 53-year-old smoker with gradually enlarging neck mass with a pertinent personal social history of 19 pack years smoking. And then from the physical exam, this is also corroborated by the 3 by 3 centimeter left anterior neck mass, which moves with deglutition. So from here, again, we establish the goals from the very start that we want to resolve the health problem. So we want to prevent and minimize the risk of a disease recurrence, and then we want to increase the survival rate, minimize risk of complications, and we want to have practical considerations for this patient. So from the start, this must already be established. And then from there, we come up with a clinical diagnostic process based on pattern recognition and prevalence, previously discussed by Anne. So this is how we come up with a clinical diagnosis. So we also noted the importance of being able to identify the different diagnostic modalities, not just based on studies, but also based on cost, availability, also previously discussed by Kate. So in this point, since the patient already had workup done in previous institutions, we have to advise the patient at this point na on the yun po, mentioned benefit, risks, and costs. So instead of having that parang step by step which test to come first, we can explain to the patient the importance of having those tests done. So this requires knowledge on the indications on certain diagnostic tests and the costs as well. And then moving on, when we're establishing the clinical diagnosis for this patient, again, with the paraclinical diagnostics, here we can see that already mentioned po, sorry. When we're now selecting treatment options, also mentioned by Kiel previously. So when we're explaining to the patient the benefit, risk, cost, availability for total thyroidectomy compared to lobectomy, it should be made clear to them so that there's adequate consent, informed consent for this patient. This is done preoperatively, so this must be made clear to them that for total thyroidectomy, the benefits are as indicated, so significant survival rate, removes contralateral lateral microscopic disease, and less anxiety for the patient, as discussed with, of course, the risk of possible vocal cord paralysis. For the lobectomy, there's the benefit of no need for lifelong thyroid hormone replacement, but with an increased risk for recurrence rate. So when we're presenting treatment options, we mention all of this, and then we involve both the patient and then their relatives in choosing the ideal management. And then after that, when we decided on the definitive treatment, we also involve them in this treatment process where we provide psychoeducation and psychosocial support through, and patients are advised on optimization, screening, and operative materials. So this is how we can reassure the patient that there are quality standards maintained during the surgical operation. This will include informing the patient that there's intraoperative evaluation, there's hemostasis check, correct count of materials, among others. So these are the things that can help allay the anxieties of the patient and their relatives preoperatively. And then on the advice on health maintenance and disease prevention, so this patient will be provided adequate pain control, thyroid hormone supplementation, calcium supplementation, and follow-up, also previously discussed by Kiel po. So for monitoring, it's advised that the patient follow up after 1 to 2 weeks post-operatively. And then the patient will also be informed that for papillary thyroid cancer, also as discussed, there's the 5-year survival rate is very good, very high. So for follow-up, we'll want to take note of the following. We want to take physical examination just to make sure that the post-op site is well opposed, no bleeding. We can take biochemical tests, neck ultrasound, and further imaging if relapse is suspected. For prevention, we just want to avoid the risk factors for this, so that's radiation exposure. That concludes the report poster. Here are our references.
Okay. Okay, why don't you proceed with the journal? Okay.
So for our journal appraisal.
Okay, so we picked a journal po based on the case given to us po. So this is also about po thyroid mass or anterior neck mass. So our patient po is EN, a 53-year-old male from Caridad, Cavite, with a 19-pack-year smoking history with no known comorbidities. No previous hospitalizations or surgeries, with a 3-year history of gradually enlarging anterior neck mass on the left, initially marble-sized, with no noted hyperthyroid or hypothyroid signs and symptoms. So there were also no noted obstructive nor metastatic symptoms. So enlargement of mass prompted consult and workup, where the patient was revealed to have subclinical hyperthyroidism, And thyroid ultrasound revealed findings suggestive of multinodular goiter thyroid spore. However, FNAB results or fine needle aspiration biopsy results were non-diagnostic. So these led us to a clinical question, which is among Filipino patients with anterior neck mass presenting with non-diagnostic fine needle aspiration results of anterior neck mass, can thyroid ultrasound, particularly the thyroid scoring, be used to decide treatment approach? So, the population is Filipino patients with anterior neck mass with non-diagnostic FNAB results, and the diagnostic use is thyroid ultrasound results, particularly the thyroid's risk classification system, and the expected outcome is can it be used to decide treatment approach for those population? So next po.
Hello. Sorry po. I think nag-freeze lang po si Kate. So just to continue on from where she left off po. So the outcome is the treatment approach decision. And then here is our chosen article and summary. So apologies po, we weren't able to document the how we came about with this, but we established this search strategy for this patient. And so the chosen article and summary is this article using the ATA and ACR thyroid sonographic classification as adjunctive predictors of malignancy for indeterminate thyroid nodules. So for the summary, so thyroid nodules with indeterminate cytology, post-management challenges in clinical practice. So the aims of the study was to determine efficacy of ultrasound features in navigating clinical decision-making in thyroid nodules with indeterminate cytology. So in the study was a retrospective study which reviewed ultrasound imaging from 186 adult patients with thyroid nodules with indeterminate cytology who underwent thyroidectomy at a quaternary hospital with a duration of 2010 to 2017. So the nodules were classified based on the ATA and 2017 ACR thyroid's classification system. So the documentation was made such that nodules were included if good quality preoperative ultrasound imaging and surgical pathology were available. The conclusion for the study was that using either ATA or the thyroid system to risk stratify nodules with indeterminate cytology may help clinicians plan better for additional diagnostic testing and treatment. So for the appraisal of the study,
So now we go on to the journal appraisal. So for appraising directness, so we are going to compare the journal article with our clinical scenario. So based upon the population, on the journal article, the patient it mainly comprises the patient in a quaternary academic medical center with thyroid nodules yielding intermediate FNA results. While for our patient, he is mainly Filipino with an anterior neck mass that yielded non-diagnostic FNA result. For the exposure, mainly we have thyroid ultrasound result, which is based upon the ACR thyroid's risk classification system. While for our patient, similarly, he is classified based upon the ACR thyroid risk classification system. For the outcome, the journal articles deals with the risk of malignancy based upon the surgical pathology report, while the patient you want to deal with the treatment approach decision that will be made for the patient. So the journal article was able to then answer our clinical question on the treatment approach decision, since it would give the clinician an estimated on the risk of malignancy, which is important for determining the type of treatment to offer to the patient. Next slide. For appraising validity, for the first question, was the reference standard an acceptable one? So the answer is yes. The ultrasound imaging result for each thyroid nodule were compared to the final surgical pathologic report to determine if the patient had malignancy or not. Currently, across all malignancies, the gold standard is still considered to be the pathologist's visual inspection of the tissue resection. Number two was the definition of the index test and the reference standards test independent. Yes, there is independence in their interpretation between ultrasound result in the patients with intermediate cytology and results of surgical pathology reports after thyroidectomy. Next slide. For the third question, was the performance of the index test and the reference standard test independent? No, the study is a retrospective review from patients who underwent thyroid surgery at a quaternary hospital from 2010 to 2017. It was stated that the treating physician made the decision for surgery based on nodule ultrasound features, among other factors. Hence, the performance of the index test, which is thyroid ultrasound, and the reference test were not independent. And next, last question, was the interpretation of the index test and the reference standard test independent? So this was unknown. The blinding was not stated in the journal article. The result of the index tests are blinded to the reference standard. However, it is unknown if the interpreters of the surgical pathology were blinded to the results of the ultrasound and FNAB. Next slide, please.
Hello po, good morning. So, sorry po, nakat po. Pero, the second row po, yun po yung TRADS 325 or mildly to moderately to highly suspicious nodules with indeterminate cytology po on FNAB. Yung third row po is TRADS 1 to 2 or benign to not suspicious in within nodules with indeterminate cytology. So for the mildly to highly suspicious nodules, 50 of them were malignant on final histopath, and 142 of them were non-malignant on final histopath, with 192 total yun po yung thyroids 3 to 5. For benign to not suspicious or thyroids 1 to 2, 0 of them were wala pong malignant, and 10 lang po yung malignant. So ang total lang po is 10. So with this po, the sensitivity of is 100. So 100% of the individuals with malignant nodules had a mildly to highly suspicious nodules on ultrasound in a background of indeterminate FNAB cytology. The specificity is 6.57%. So 6.57% of individuals with the non-malignant nodules had a benign to not suspicious nodules in ultrasound result in a background of indeterminate FNAB cytology. So the PPP po is 26.04 or 26.04 of the individuals with mildly to highly suspicious nodules on ultrasound had correctly had malignant nodules. The NPV is 100%, or 100% of the individuals with benign to non-suspicious nodules on ultrasound had correctly had non-malignant nodules on final histopath. The positive error po is 1.07, or a thyroids of 3 to 5 in indeterminate FNAB nodules is weakly positive enrolling in a malignancy, and the negative error is negative at negative 14.22. So at TRADS 1 to 2 has a strong likelihood for ruling out a malignancy po in indeterminate FNAB findings po. Next slide po.
So for assessing po yung applicability of the journal article to our specific clinical patient, we must account for any biologic or socioeconomic factors that may affect yung applicability of the journal sa patient natin. So first would be yung gender, yung sex. So majority of the patients in the research article were women, around 82.8%, and men were around 17.2%. And for our patient, he is a male. So I think for this case po, this is still applicable po since part naman po ng population nung journal yung both genders natin. Although mas maraming ang women dun sa journal. So the next would be presence of any comorbidities. Unfortunately, no data was presented regarding the comorbidities of the patients in the study. But for our patient naman, he has no known comorbidities. So yung assessment for this is siguro unknown po muna since there's absence of data regarding comorbidities. So the next would be yung race naman po. Hindi rin po naka-indicate dun sa journal article which specific race yung mga patients. However, the medical institutions involved are located at North Carolina as well as in San Francisco. So for our patient naman, he is Filipino and again unknown po because of the absence of data. Although we can assume na siguro majority of the patients would be Caucasians. The next would be yung age. So the median age of the patients is 57, so ranging from 44 to 68 yung ages nila, and our patient is 53 years old. So yes, this is applicable given that the age of the patient is within that range. And lastly, yung mga socioeconomic factors naman. So it was indicated in the journal that the patients are from a quaternary hospital in a first world country, and our patient is in a tertiary hospital naman po in a third world country. So we think po this is still applicable since both patients in those hospitals, the hospitals are specialized hospitals with access to ultrasound as well as fine needle aspiration biopsy, as well as specialists who are knowledgeable about interpreting such results po. So overall, appraising applicability is we think this journal is applicable still for our clinical patient given the following findings po.
So, after all that po, we individualize the results. This is where we take into account the situation of our patient. Several studies have investigated the role of thyroid ultrasound features as a predictor of malignancy, including various combinations of microcalcifications, irregular borders, and increased vascularity. With different classification systems, different risks of malignancies were suggested. So in the study, we found the role of 2017 ACR ThyRads in refining post-test probability of malignancy for thyroid nodules with indeterminate cytology. This study found that ultrasound classifications appear to be effective in risk stratifying thyroid nodules with indeterminate cytology. So, since our patient's cytology results was CAT1 ThyRads4, it is recommended that he undergo surgical intervention given a high risk of malignancy of 34.3%.
Okay. Are you done?
Yes po sir, that concludes the journal appraisal. Po sir.
Okay. So where do we start? Hmm. We can start with the journal. Let me start with the journal. Okay, let's start with the case na lang muna. Okay. So thank you for your comprehensive presentation. Let me just make some comments and then ask questions along the way. So if I were to manage this patient, no, so we have a okay. So our patient is 50-year-old male with an enlarging neck mass. So the phrase enlarging neck mass is actually a description of physicians, right? Okay. So, ano ba yung complaint ng pasyente? Tinuturo lang niya?
Sir, yung sinabi niya po mismo was lumalaki yung bukol.
Sa leeg.
Opo.
Sabi na may bukol sa leeg. Okay?
Opo.
Okay. So, kasi when you say enlarging, at least okay, you can say enlarging anterior neck mass. Okay? Okay. Anterior neck mass, the front. So right away, what you can do is to examine the patient. No? Okay. So you don't have to go through the long history. No? If I were to manage this patient in the clinic. So you examine the moment you see the patient, what's your concern? Okay. Of course, after the greetings, no? Okay. What's your concern? Sabi niya, lumalaki ang leeg niya. No? May bukol sa leeg. No? So what you can do is go right away to examine the neck. No? And then while you examine the neck, you ask more questions because you can do that, no? To save time. No? So you can ask, kailan pa nagsimula ito? Ganon, no? So she said 2 years ago. No? Okay. And then while you're examining the patient, no, you will be able to determine if there is really a neck mass, number one. No. Number two, if it's anterior sa front, you try to determine whether it is connected to the associated with a thyroid. No? But because that's the most common source of a anterior neck mass. No? Whether it's on the midline or on the lateral. Okay? Kasi anterior can be midline, can be lateral. No? Okay. So if the mass is lateral, you think of lymph nodes. Okay. So if you think, if you determine that the mass is in the midline or paramedian, no, then you think of the thyroid. No? Okay. So once you determine that it's in the midline or the paramedian, paratracheal, you ask the patient to swallow. Okay. And then if it moves with deglutition, then that's it. Most likely you have a thyroid mass. And then after that, you try to complete your physical exam. And then if you need to ask more questions, you can do so. No? Okay. So example of questions that you may ask, have you been treated by other doctors before? Sabihin niya, yes, no? I was treated by a private physician, no? And then ganon, story telling. Then did you have an ultrasound before? Yes. What are the results? Wala, no? Sinabi niya wala. Ay, sasabihin mo, bakit hindi niyo tinago yung ultrasound ninyo? No? Okay. So as you go along interacting with your patients, you can also give them some pointers, yung mga health education. You tell them, yung mga examination results niyo, itatago ninyo. It's just like your birth certificate, itatago niyo. No? Importante yon. Huwag na iwawala. No? Kasi the next physician who will see you will ask for them, no? And that will help you help us in the diagnosis as physicians, no? So tell them right away a lesson to keep their medical, kasi a lot of patients, I suppose even us, no, even you don't keep your records properly or no? Okay. So you have to give them some health education, no? So going back, kung midline, ang mass moves to deglutition, most likely it's thyroid in origin, no? And then you determine the other characteristics of the mass. Okay, so you said that the mass is 3 centimeters. 3 ba? Okay. 3. And then, okay. So in your presentation, the other characteristics that you have to mention, which I don't know whether you placed them already there. Did you mention whether it's solid or cystic?
Sir, predominantly solid daw. Solid po. Yung
No, on your palpation, were you able to palpate this patient's mass before
Yes
the
po.
operation?
Yes po, sir. Firm po yung consistency po.
Now, firm is not the same as solid or cystic. No? Okay. So when you examine any mass, aside from the size, no, you determine the nature of the mass, whether it's solid versus cystic or combination, complex. No? Okay. Because that will give you a clue on the diagnosis. No? So whatever you do on your physical examinations, you're trying to find some clues to help you in your diagnosis. If it's cystic, most likely, probability-wise, it's benign. Okay? If it's solid, it's 50-50. Doesn't mean anything. Okay? But if it's cystic, most likely it's benign. Okay? So, and then yung consistency, that's where you come in, whether it's hard, it's firm, or soft. Okay? That's a different category now, which is not being taught in the books and also in medical schools most of the time. No? Iba yung categories ng nature of the mass, solid versus cystic, or the consistency, whether it's firm, hard, or soft. Okay? So usually firm yon, di ba? But if it's hard, bony hard, stony hard, then that could be a clue for malignancy. Okay? But it's firm, 50-50, doesn't mean anything. Okay? It could be benign, could be malignant. Okay? If it's soft, ganun din. No? Okay? So, but you have to combine the two. Sometimes you can have a hard cystic because of the tenseness of the mass. Okay? Masyadong tense yung mass, it can feel solid. No? Okay? So it can feel hard and it's cystic, but it feels hard because it's tense. No? Okay? So co-combine mo yung dalawa. No? Then the other characteristics that you have to, aside from saying that it moves with deglutition, you have to determine whether it's movable or not, whether it's fixed or not. Okay? So there are two kinds of fixation on the thyroid nodule, which could be malignant. No? So if you stabilize the trachea and then you try to move the nodule, thyroid nodule, you cannot move it. It's really fixed. Then most likely it's fixed to the paratracheal fascia. Okay? Yung fascia, yung ano. Okay? So you would suspect malignancy. Okay? Now, if you ask the patient to
Sorry po, the connection is choppy po, that you're coming in po choppy.
Can you hear me now? Nawala.
Yes,
Yes
po,
po,
sir.
Sir.
Okay. So where was I? So you have to determine whether it's the nature of the mass, whether it's solid or cystic, and the consistency. These are two different parameters, no? Okay, firm, hard, or soft. Okay, but I usually use two, whether it's hard or non-hard, because it's very subjective from firm and soft. Ganon, no? Okay, hard or not hard. Okay, as I said, there are two kinds of fixation. If you don't allow the patient to swallow, then you try to move the thyroid mass, it doesn't move. No, okay. And then most likely that's probably a malignancy, which most of the time is anaplastic carcinoma, okay, because it's invading the paravertebral fascia, okay. Now, if that mass, if you fix the trachea and it still moves, then you call that mobile, no? Okay, it's not fixed, okay. But if you move it and it moves to the trachea, okay, if you don't ask the patient to swallow, but you move the mass, it's fixed to the trachea, then you say that the mass is fixed to the trachea, no? Okay, again, you suspect malignancy there, no? Okay, clear? That's a refinement of thyroid physical exam, okay. Then the other thing that you have to determine whether, aside from the size, okay. Of course, in the thyroid, you try to determine whether there's tenderness or not, okay? You palpate it. If it's tender, it could be some thyroiditis, no? Okay, thyroid abscess, no? And then you look for the associated signs of invasion, like hoarseness of voice, no? And also the neck nodes, no? Okay, so based on your physical examination, okay, let's leave for a while the F&A part of the history, okay? Because this was done in PGH now, okay? Assuming that you're seeing this patient for the first time, okay? So what will be your diagnosis? Yung mga yung Pemberton signs, you really don't have to go through that. Yung pinaka-basic lang, no? So 3 by 3 centimeter firm, solitary nodule, okay? When you say nodule, it's solitary nodule. No? You say nodular on your slide, no? So that's solitary nodule, okay? And then non-tender, moves with deglutition, then you can say that it's not fixed. You add another data, then it's not fixed, no? Okay. And then, okay, usually pag malilit lang, you don't expect those Pemberton signs anymore. You don't have to look for it, no? Okay. Pag malaki na, no? Okay, that you suspect something. Then negative lymph nodes. Okay, based on those data, what will be your clinical diagnosis? You mentioned multinodular non-toxic goiter. Okay, itong picture nito, okay, hindi niya madi-discern. Sige, i-flash my picture. Pero nasa operation na ito, no? So when you take a picture of patients, i-outline mo lang yung mass through a pen, no? Para makita, no? Okay. Hindi mo talaga makikita yung mga maliliit if you take a picture, no? So you put a dotted lines. Can you see my mouse? Nakita mo
No post.
nakita mo yung mouse ko? Hindi.
No
Wala.
post there.
Sir.
Oh, sige. Wala ko makikita. So just put dotted lines along the border of the mass to indicate that there's a mass underneath. Okay? So 3 centimeters. Okay. So you mentioned multinodular non-toxic goiter versus CA, no? Secondary, no? Okay. I'm just wondering, where did you get that multinodular non-toxic goiter as a diagnosis of a thyroid disease? Was it taught in medical school, in your school? We have 3 different schools here, di ba? UP, okay, FEU, and OM, and UE, 4. Was it taught in medical school?
Sir, our basis lang po for parang considering yung multinodular. Kasi nung nagpalpate po kami, parang may multiple nodules po siya. So parang just based on that clinical finding. And then,
Were you able,
nabasa
did you indicate? I thought did you indicate the other mass on your PE?
no.
Sir, upon PE po kasi, yung very palpable lang yung, tas yung other nodules po kasi, hindi naman na-indicate because it wasn't part of the PE but of the ultrasound na upon the initial visit po sa OPD.
Okay. And kasi okay, ang scenario kasi natin ngayon is you're seeing this patient for the first time. Kayo ang tumitingin. Now, okay. If you feel several, if you were able to feel 2 nodules, no? Okay, either right or on the same side or both sides, then you have the right to say it's multinodular, di ba? That's rational, di ba? But if on palpation, you can feel only 1 nodule, no? Wala pa yung ultrasound, ha? Okay? Okay. Not be influenced by the ultrasound yet, ha? Kasi pinipi mo pa lang, no? Okay. So you say it's a solitary nodule based on your PE, right? Did you get my point? Kasi may connotations yan eh. Solitary nodule has a higher prevalence for malignancy compared to multiple nodules. No? Okay. Do you know that? Do you know that, or first time to hear about it? First time?
First time.
Okay. So ito yung in-impart ko sa inyo, ha? So kasi when you diagnose a patient, you go by probability eh. No? Okay. You have to gather all the data, the information that you know, and then you go by probability. Yan ang tinatawag na prevalence, di ba? Okay. So if you have a solitary nodule, just this number of nodule per se, yun lang, ha? If you have solitary, you have a higher prevalence chances of malignancy compared to multiple nodules. Okay? Take note of that. Na? Okay. Mas takot ako kung solitary nodule kaysa multiple nodules. Okay? Okay. Now, let me go back to my question. Kasi importante yung diagnostic labeling eh, no? When you put out a diagnosis, you have to put a phrase or statement, right? Okay. And that statement should be able to identify what the patient has, and it should be as specific as possible, as much as possible kung pwede, di ba? Okay. So, you mentioned multinodular non-toxic goiter. Tama? Tama ba?
Yes po, sir.
Okay. So, where did you get, I'm asking now because I'm trying to respect yung yung mga schools ninyo. Okay. I'm trying to see whether I can make sense with that, what I'm going to say. No? So, saan nyo nakuha itong From medical school? Pare-pareho kayo? UP? I'm also from UP. UP. And then FEU. Yan ang tinuturo sa inyo?
Sir, I will say po based my school, pero yes po, yun po yung tinuro. Parang may classification po kasi whether it's solitary versus multinodular po. Then toxic po if may presentation po siya of hyperthyroidism po, and non-toxic po if wala pong presentation po.
Okay. Sige. Ito yung sasabihin ko sa inyo, ha? Makinig kayo, ha? There is such a thing as clinical classification of goiter. Okay. A goiter is, as we define goiter loosely as any disorder of the thyroid gland. Sa ngayon, ha? That's the present connotation of goiter. Before, when you say goiter, it means something benign. Iodine deficiency, no? Okay. Sporadic goiter, no? Cannot benign. But nowadays, we use the term goiter loosely as any disorder of the thyroid gland. Okay. So the thyroid gland can be, when there are changes in the thyroid gland, it can be diffusely enlarged or it can be nodular. Okay. May diffusely enlarged and then may nodules. Tama? Okay. So the clinical classification that that is being used is that number one, if it's diffuse, then you determine whether there is hyperthyroidism or not. Now, that's why you say diffuse toxic goiter. Okay? Kung walang signs and symptoms of hyperthyroidism, you call it diffuse non-toxic goiter. Can you raise your finger para I can see? Kung kakaintindihan tayo, okay? So, kung nodular naman, again, you look for, after examining the patients, no? Kasi clinical diagnosis ka na, ibig sabihin na-examine mo na yung pasyente, no? So, if there are signs of hyperthyroidism, then you say nodular toxic goiter, okay? If there are no signs of hyperthyroidism, you say nodular non-toxic goiter. Tama? Basically, apat yon. Okay? When you say non-toxic, it could be euthyroid, normal yung ano niya, thyroid functions niya, or hypothyroid, pwede yun, no? Okay? Yung toxic is hyperthyroid. Okay? Apat yon. Okay? Then under nodular non-toxic goiter, you can subdivide it into two. Yung sinasabi niyo, multinodular non-toxic goiter, and you can say solitary nodular non-toxic goiter. Ganon, isa, no? Okay? Just to differentiate the two, multiple and solitary. Okay? Kasi may implication yan eh, no? Okay? So, kaya ako tinatanong sa inyo because I'm also looking at the WHO classifications, no? So they're teaching that, no? But when they mean a multinodular non-toxic goiter, it means yung mga benign conditions, no? Like colloid goiter, no? Colloid adenomatous goiter, etc., etc. No? Okay? So for me, personally, I use this multinodular non-toxic goiter as part of the clinical classification. It's not yet the diagnosis. No, it's not yet the diagnosis. You start with those that clinical classification, and then you go further, okay, to determine what is the specific diagnosis. Okay. Example: you have nodular toxic goiter. Okay, so that's a clinical classification. So the specific diagnosis there is a hyperfunctioning thyroid nodule because it's solitary. Now, gets? And then if you have you have diffuse non-toxic goiter, okay, you can have hypothyroidism. Okay, diffuse non-toxic ito, you can have hypothyroidism, or you can have the so-called colloid adenomatous goiter, but it's in the early stage, it's still diffuse. Okay, so we know that the colloid adenomatous goiter has a spectrum. It starts with the diffuse, then it becomes nodular, pwedeng solitary, or magiging multiple, no? Okay, so if it's in the stage of major diffuse pa, you call it diffuse colloid adenomatous goiter. That's one of the condition that will present like as diffuse diffuse non-toxic goiter. No? Okay, the other one is hypothyroidism. No? Okay. Now, kung diffuse toxic goiter, then you're talking about hyperthyroidism. Then, if you have eye signs, okay, you have tremors, no? Then you call that Graves' disease, di ba? Specifically Graves' disease, no? Kung walang eye signs, walang exophthalmos, then you just say it's hyperthyroidism, no? Non-Graves' disease. Okay? Do you follow? Are you following? So, taas lang yung finger na para okay. Now, going to the multinodular non-toxic goiter, you can have MCAG, you can have malignancy, okay? You can have chronic thyroiditis. Marami yan eh, na? Okay? If it's solitary, non-toxic goiter, it could be the nodular part of the colloid adenomatous goiter. It's a solitary colloid adenomatous nodule, okay? Or sometimes it can present as a colloid cyst, no? Just cyst lang, okay? One cyst. So it's still part of the nodular non-toxic goiter. Okay? So nakikita niyo maraming klaseng medical diagnosis na that will constitute the nodular non-toxic goiter. Okay? So you have to specify it. Okay? Do you follow? Okay. So when you say, yeah, importante yung clinical diagnosis because that's the starting point for all the decisions making. No? For the paraclinical diagnosis, even for the treatment. Now that's the starting point of every decision making. No? So kaya yung kanina when somebody, okay, Paul Garcia, Phil, you were discussing about the treatment, sabi ng yan ang gusto niya, but you always saka binaliktad mo kagad, no? Nag-CA ka kagad, hindi ka you didn't consider the first one, di ba? Okay. But I'm telling you, you start with the diagnosis. Na? You have to be convinced with your primary diagnosis. No? Then you decide what to do next. No? Okay? So when you palpate it, it's solitary, di ba? One nodule. Okay, so at that time, you can say that you have a solitary thyroid nodule, non-toxic. Okay, goiter. Okay, and then from there, you have to differentiate what is it? Is it cancer or not? Okay. Okay, so non-cancer could be the colloid adenomatous nodule. Okay. Okay. If there are signs of malignancy, like it's hard, it's fixed, no, it's solid, then you think of malignancy. No? Okay. If there are no signs of malignancy, no, then you settle for a benign colloid adenomatous nodule because that's the most common, okay, among the nodular non-toxic goiter. Now, yung solitary. Now, okay. Do you follow? Mukhang nahirapan kayo? Kayo nahirapan?
Sir, question po.
Sure.
Where can we find po the classification po, the subclassification po of the multinodular non-toxic goiters po?
Where?
Opo, reference po. We can seem to find it po in our references po.
What's your question again? Where can you find the
The
classification?
subclassifications po of the multinodular non-toxic goiters po.
Okay. Where? I really don't know. I've been looking for it. But during my residency years, mas gusto ko pa ngayon. During my residency years, that's how I was trained. No? Okay. Okay. So it makes sense. It makes sense, di ba? So once you have a goiter, you do a clinical classification first, whether there's toxicity or not, and then whether it conforms to the diffuse or the nodular. No? Okay. Then after that, you dissect it further, whether it's CA or non-CA. If it's CA, whether it's papillary, follicular, anaplastic, medullary. If it's non-CA, you dissect it further, whether it's colloid cyst, if it's a solitary mass, which is cystic, no? Then you have the diagnosis of colloid cyst. If it's solitary, na soft naman, you go by, it's hard to differentiate it from the malignant one, like papillary, kung minsan soft pa rin na papillary in the initial stage, then it's a toss-up between papillary CA versus colloid adenomatous nodule. No? Okay, so if you go by prevalence, you think of colloid adenomatous nodule, pero you classify it as not very certain. That's why you need to do a paraclinical diagnostic procedure. Okay, let me just answer your question. As I said, I cannot find it, but I have a write-up on that. I'll give you the reference. Okay, I have a lot of manual on that. No? Okay, okay, and remind me. Okay, so pattern recognition. Okay. Okay, after that, okay, sabihin natin meron kang na-influence ka na meron siyang ultrasound, okay? Pumasok na yung ultrasound sa data mo, okay? So, ano yung ultrasound? Sige, can you flash the ultrasound? Okay. So before that, as I said, if I were the one managing this patient, if I feel one solid nodule in this 50-year-old male, no, sabihin natin solid, no, it's not fixed, no, it's not, it's 3 centimeters, no nodes, no, okay. So I would suspect malignancy right away, no, solid kasi, no, solid, no, so I would put it at probably 60 to 70%, then 34 colloid adenomatous nodule, no, okay, okay. So again, it all depends on your experience. Okay lang yun kung ano ka. If you're not so experienced like me, then you can make it the other way around, no, okay, benign first, and then malignant, no, but you have to quantitate it, no, whether you're quite certain or not, no, okay. So because that will be the starting point of whether you need a paraclinical diagnostic procedure. Okay, an example for this, a further amplification of this, if I saw this patient with a cystic mass solitary, I would say that's colloid cyst right away. Okay, cystic, cystic, so colloid cyst, no, so I will probably do a needle aspiration already. I don't need your ultrasound, okay? Diretso na, because it's cystic, okay? The needle aspiration will be part diagnostic, partly therapeutic, no? Ganon, diretso, okay? So anyway, meron siyang ultrasound, lumabas, okay? So ang lumabas, meron siyang mixed cystic and solid hypoechoic nodule on the right side, right lobe. So meron pala siya doon, pero gaano kalaki? Ito, less than 1 centimeter, 2, di ba? Okay, sub-centimeters, okay? So based on the ultrasound, you now have multiple nodules, okay? Which you won't be able to palpate that kasi sub-centimeter lang on the right side, no? So you can now say, based on the ultrasound, it's multiple, okay? Multiple nodule, no? Okay. Okay. But if you base it on your PE, you can just say it's solitary, di ba? Okay. So you can specify on your diagnosis, if you think it's a multinodular non-toxic goiter, you say it's based on the ultrasound. Okay. Specify it, no? Okay. And then the other finding is that there is a Thyroid's 4, the radiologist interpreted as Thyroid's 4. Ano yung mga points? Okay. So they use so many parameters in computing for the thyroids, no? Okay. So they have 5 points ba ito? Nakalagay ito, 5 points. Okay. So they use the whether it's solid or cystic. Cystic usually mas konti ang points, no? And then yung wider than tall, which one has higher point? Tall or high? Wide?
Taller than wide po has higher points.
Okay. Taller than wide, na? Okay. So ito, mas konti ang point, na? Then smooth margin, again, na? Konti lang, di ba? Mas maliit ang point kaysa compared to irregular margin, na? And then micro calcification versus macro calcification, na? So macro has lower points, smaller points, and then compared to micro, na? Okay. But anyway, you cannot, usually you just accept what the radiologist will tell you. Thyroid's 4 ang nilagay niya after computing for all the points. Na? Okay? So yung wala siyang binanggit nito, but most of the time, how many of you have seen other thyroid ultrasound reports? I don't think this is the first one that you saw. How many of you have seen more other than this one? Can I have show of hands? Nakakita na kayo ibang thyroid ultrasound reports na may thyroids? Wala pa?
Sir, parang may ano lang po, values, kaso lang wala pong thyroid scoring nilalagay po sa previous.
Sige, tingnan ninyo. Sige, I would suggest that you look at the other reports that you receive or that you can encounter in patients with thyroid. No? So makikita ninyo, I'm sharing you my experience. No? Nowadays, with the advent of the thyroids reporting, before it used to be biroids lang sa breast. No? Ngayon, sinasama nila yung thyroids. No? Okay. And parang may learning curve pa sila, kaya magulo. No? Okay. Okay. So you can see that sometimes they report it yung sa right side, they will report it thyroid 3. No? And then yung isa, for every nodule, i-report nila. Kung multiple yan, nakakagulo na yan, di ba? Okay. Kung 10 yung nodules yan, sasabihin niya thyroids 2, thyroids 3, thyroids 4, ganun. No? Okay. So ito, probably thyroids 3 yung una, yung sa right side. Ito yung sa left side, thyroids 4. No? Okay. So once you have this thyroids 4, may recommendation sila to do FNAB, no? Okay. Fine needle aspiration biopsy if it's greater than 1.5. So this one is 3, di ba? So all doctors, practically all except for a few like me, no? Okay. I usually would correlate it with the clinical findings. I don't just accept yung mga recommendations ng radiologists, which is a common practice among physicians. No? Okay. So that's one lesson one remark that I want to share with you in terms of community practice. Okay. So a lot of physicians, you might fall into this trap also because you tend to believe the radiologists, whatever they say. But remember, they always say recommendation lang, di ba? Recommendation. Okay. So you don't have to really follow. Okay. So what you're gonna do is to correlate itong ultrasound findings nito with the clinical findings. Di ba? Okay. Kung balikan mo yung ikapa mo ulit yung mass, na? If it's solid, na? Okay. And then medyo hard ng konti, okay, sabihin mo, medyo hard ng konti, na? Then, sabihin mo, ay, baka tama nga ito, baka CA nga ito, na? Okay? Okay, babalikan mo, na? Okay? Now, if you, one day, binalikan mo, soft pala yung mass na yon, hindi pala solid, pwede din magkamali yung ultrasonographer, ha? Cystic pala, and then you can say it's most likely benign yan, na? Okay? Okay, you can make a decision on your own, na? Basta i-rationalize mo lang, na? Okay? Put down on records what are your findings on your correlation, clinical correlations, na? Okay? So ito, so remember that, ha? Yung thyroids, na? Okay. Okay. Now I'm torn between jumping to the journal. Ito yung basis na natin, di ba? Needle aspiration, indeterminate, hemorrhagic aspirate. Na? So it's very important that magaling mag-aspirate yung physician, no? Whether he be a surgeon, endocrinologist, or a general physician. No? Yung 3 centimeters yan, kayang-kayang aspirate na yan. Di ba? Okay. And there's a technique for that. No? Okay, another community issue which I want to share with you, which we want to avoid also. Nowadays, practically a lot of people are relying on ultrasound guided, even though if it's palpable already. Na? Okay. It's been more accurate, but most of the time, extra gastos lang yon, na? Kasi mas mahal if you have added ultrasound guided. Na? So, compared to before, hindi pa uso yung ultrasound guided, kapa-kapa lang, na pwede, na? Okay. So you do an ultrasound guided needle biopsy of a thyroid mass kung di mo makapa, na? Okay, kung maliit lang. Okay. So napapamahal yung mga gastos ng mga pasyente nowadays, na? Okay. So because of that ultrasound, nagiging uso yan no? Kasi lot of because of the practice of the physicians and because of the encouragement of hospitals para kumita, no? Okay. So you do an ultrasound. Kasi you get more income with procedures, di ba? Rather than consult, no? Or kung operations, walang masyado kasi yung PF pumupunta sa doktor, di ba? Okay, but if you use the equipment, no, you have more income to the hospital, no? Okay. So, okay, as I said, the other concern is aside from the ultrasound-guided biopsy that is very rampant, yung reporting, masyadong maraming reporting. As I said, learning curve nila, maraming may Thyroid 4, nakalagay dyan, no? Okay. And most of the time, when I have Thyroid 4, I correlate it with clinical findings, especially those with multiple nodules, no? So usually, benign lang yan, no? Okay, observe ko lang, medical treatment, no? Okay. So I don't go into the biopsy as recommended by the radiologist. But before I decide on that, I have to discuss it with the patient, educate the patient, no? Okay. So Phil, hindi pwedeng sasabihin natin gusto ng pasyente, na? Okay. So before you of course, in the end, it's what they want, but you have to educate them first. You have to explain to them, no? Ano yung the real situation, what are the pros and cons, no? Okay. Okay. So that may agreement siya, and you also want to save yourself kasi hindi ka naman, we doctors can never be 100% correct all the time, di ba? Okay, but we go by probability, na? Okay. Okay, so lumabas negative aspiration, hemorrhagic. Ibig sabihin, walang nangyari, di ba? Walang nangyari, di ba? Okay, let's now go to the journal. Hindi ba pareho lang yung wala rin nangyari, basta I suppose ano yung 2017 study na yon? 2017 studies on the accuracy of the thyroid reporting, di ba? Tama? Yan, yung 2017 thyroid reporting. Okay. So ano yung sensitivity, parang kasi when you have indeterminate diagnosis on needle aspiration, parang you go back to the what is the, kahit na hindi ka nag-aspirate, ano yung accuracy ng thyroid reporting? Tama? Okay. So I don't know why they have to conduct such a study, di ba? Okay. So pwede na yung isa, di ba? Kasi when you say indeterminate, parang walang nangyari, di ba? Okay. So you have to remember that there are various types of diagnoses. You have the clinical diagnosis, you have the paraclinical, which is the ultrasound here, no? And then you have the needle biopsy, which is also paraclinical, no? And then later on, the histopath diagnosis, usually 4, no? If you want, pag namatay yung pasyente, you can have a post-mortem diagnosis, no? So 5, di ba? Okay. So etong 4 nito, aside from the post-mortem, you do not forget your clinical diagnosis, no? It's also as important, and it carries a lot of weight. Okay? Kaya nakikita niyo, have you seen all the diagnostic reports that you have received? X-ray, CT scan, ultrasound. On the bottom of the report, it always says there, talk to your physicians, okay? Correlate these findings. This is just a findings based on what we saw, no? But this must be interpreted by your physicians, and then it must be correlated clinically. Am I correct? Have you seen report like that? Phil? Ira? Yeah? Okay. So, wag niyo kakalimutan yung clinical diagnosis. Even the radiologists, the mga imaging experts, they always say that you have to go back to your clinical diagnosis. no? Okay? So importante 'yon, no? So clinical diagnosis, huwag niyo kakalimutan. Then needle biopsy, once you have the needle biopsy, then kahit na anong report, kahit na positive, kahit na non-hemorrhagic, ibabangga mo pa rin sa clinical mo, no? Ultrasound, ganun din, ibabangga mo sa clinical mo. Then come out with the diagnosis, no? Okay? And then, even the histopath, later on, baka lumabas follicular CA, baka lumabas anaplastic, iba-iba, di ba? So, kung lumabas medullary or anaplastic, then I will ask the pathologist to review it. Baka mali, di ba? Okay? So, kasi clinically, mukhang hindi siya anaplastic. Okay? Okay? So, importante yung clinical diagnosis, ha? So, when you talk about the pattern, okay, tapos na tayo sa journal, ha? I won't discuss the other parts of the journal. Yan ang basic issue doon, no? Okay. So, you just go back to your, parang go back to the, what is the original results of the paper, no? Okay. Na kung thyroid's 4, ano yung positive rate or negative rate for malignancy? Di ba? Thyroid's 5, ganun din. No? Thyroid's 3, ganun din. No? Okay. So, I hope we can do a study in the Philippines. Ganon. So, dapat sa PGH, dapat meron din ganon. No? So, lahat ng pasyente na operahan na may thyroid's 4-3 reporting, ibabangga mo dun sa histopath. Titingnan mo yung accuracy rate ng mga reporting ng mga radiologists. No? Okay. But make sure, kung minsan mahirap din gawin yon, especially multiple nodules, they have to really identify ano yung thyroid's 4 na naka-report doon. Baka hindi nila ma-identify, halo-halo na yon, no? Okay? Kung solitary, okay lang, mas madali, no? Okay. Kasi a lot of times may multiple nodules, may dalawa dyan, thyroid's 4, yung tatlo, the rest of the nodules, thyroid's 3, gano'n, no? Okay. Okay. Now, let's now go back to the diagnostic process, yung pattern recognition and prevalence. Na? When you say prevalence, na, in this particular patient, na, we're talking about whether it's common or rare. Na? Okay. Pero ang first priority mo is pattern recognition. Na? Okay. So where do we start? Okay. So yeah, okay, let's go back. 53-year-old male, 3-centimeter nodule, no? Hemorrhage, no information from the FNAB, no? And then solid, okay. Not fixed, no neck nodes. And then the, ilan ang pulse rate niya? Non-tachycardic, no?
Non-tachycardic po.
Okay. So I like to emphasize yung pulse rate is very important in the diagnosis of hyperthyroidism, no? Then, but i-correlate mo dun sa configuration of the thyroid gland. If it's diffuse and then you have a tachycardia or 90 beats per minute, then you suspect hyperthyroidism. No? But if you have a nodule and then you have a thyroid function pulse rate of 76, okay, non-toxic siya. Okay? So which brings me to the point, magja-jump lang ako ng konti, baka makalimutan ko kasi yung algorithm na binigay ni, who is the second presenter? Okay. Who was the second presenter after Ira? Si Kate? Ikaw ba? Yung algorithm?
Si Ann po.
And yung algorithm mo may TSH, di ba?
Yes po, Sir.
Okay. Ako, I don't practice it. Na? Okay? I don't do that. Na? Okay. Makakalito lang. Saka, you can tell already. Na? So, if you have a diffuse goiter and then nasa borderline 90%, 90 beats per minute, actually 100 is a cut-off, di ba? So, ilo-lower ko lang, i-strict ko lang, 90, na? Okay. Then, I would go for, thyroid function test, na? Because I might miss out on the, hyperthyroid, na? But, if it's diffuse, and then 60 per minute. No, hindi ko na kailangan. Baka i-treat ko na as hypothyroidism or colloid adenomatous nodule. And if it is solitary, may mga nodules na, if it's less than 90 ang pulse rate, it's usually non-toxic siya. No? Okay. So 90, my experience shows that more than 95% are not toxic. So if you get the TSH, thyroid function test, malilito ka lang. Parang itong pasyente nito, na? Okay? Kasi yung mga TSH na yan, hindi siya masyadong accurate all the time, na? Okay? Nagpa-fluctuate yan eh, na? So you came out with a low normal in this particular patient. Magkakaproblema ka naman nung sa endo, baka i-treat nila as hyperthyroidism. Di ba? Malilito lang sila, na? Okay? So I don't usually order for this test anymore. If it's go by clinical, no? Okay. If it's a solitary nodule, ang pulse rate is more than 90 per minute, then I go for the TSH, the T3, T4, because I'm suspecting solitary hyperthyroidism, no? Okay. Okay. Importante yung pulse rate, ha? Plus the configuration of the thyroid, whether it's solid, it's nodular or diffuse, no? So going back, prevalence. So my diagnosis will be, number one, okay. Sige, let's go by your, sige, yung sa inyo. Kasi sa akin, it will be CA, then number 2, colloid adenomatous nodule, if it's solitary. Okay. And then, yung sa inyo, sabihin natin, yung when you say multinodular non-toxic goiter, you're referring to the colloid nodule, no? Colloid nodule. Then number 2 will be your thyroid CA, no? Okay. So the pattern there of recognition is that there's a nodular non-toxic goiter. Okay? Okay. Walang signs of malignancy, but you can probably you can use that to support your nodular, yung colloid nodule. Walang signs of malignancy, di ba? Okay? Okay, but for me, because of my experience, pag solitary, usually I suspect malignancy, no? Okay. And then the other factor, which I don't usually use, no, is the male. Sinong nagsabi, yung kaninong presentation yon?
Actually, sir, yun po, parang different sources po yung nakikita ko na more prevalent daw minsan sa female. Pero parang nagbasa rin po pala ako ng Harrison's right now. Tas risk factor din po pala ang male gender for malignancy po. Based on Harrison's po, sir.
Yeah, kita mo, malilito kayo, no? Ang dami, no? So, in terms of prevalence, mas marami talaga yung mga babae. Okay? Okay. Pero in terms of sa lalaki can have, no? Male can have multiple nodules also, no? Okay, yung mga colloid adenomatous nodules, no? But the books are all usually the mga Western books are usually saying that there is, let's say, for 100 solitary non-toxic nodule, no, majority will have CA. Yan ang sinasabi nila. Okay? Okay. Yan ang basis for saying the male has a higher risk, no? Sabihin natin 60%, no? And then for females, kinumpare nila sa females, for females, 100 females with solitary non-toxic nodule, probably about 10%, ganon, or 20% lang. Yan ang basis for saying that you have a higher risk for male, no? Okay? Okay. So, yan sa akin, I don't usually use the male factor, no? I just mention it here for discussion, no? Okay? I base it on the clinical findings, kung ano yung nakikita ko, no? Okay? Kasi pag cystic nodule yan, lalaki, wag mo sasabihin, ay, CA na yan, because lalaki siya, no? Hindi, no? So, kung cystic, sabi mo, colloid cyst siya, no? It's benign. Okay, so rely on your clinical findings rather than on the sex, no, or even the age, no, the age, no. Okay. So so these are the pattern for yung non-toxic solitary nodule with no neck nodes. Now this is the pattern for nodular colloid nodule and also CA, dalawa, no? So which one will you choose in terms of prevalence? Okay. Now if you okay, both are common, di ba? Both are common, di ba? These are not rare, di ba? Walang rare naman dyan, no? But suppose you put a TB. Number one, sabihin natin, TB ang nilagay mo. TB of the thyroid nodule. No? TB of the pwede mangyari yan, di ba? TB of the thyroid nodule. Then you invoke now the prevalence. So you won't put TB as number one, no? Okay, you put it as number 2 or number 3, di ba? That's what is meant by prevalence, no? Okay. So huwag ka maglalagay ng, if you have two differentials, no? One, you use prevalence in terms of which one is more common, and then lagay mo sa number 1 yung the one which is more common, no? Okay? Yung pinaka hindi siya common, rare, lagay mo sa number 2. Pero because it presents with the same picture, di ba? Okay? So parang to amplify on this, parang yung COVID natin ngayon, di ba? May symptoms of flu, no? So kung walang COVID, we don't diagnose a patient to be COVID, di ba? We give a diagnosis of flu. Pero pumasok na yung COVID pandemic, you have flu symptoms, number 1 na yung COVID, di ba? Number 2 yung flu. So that's how you use the prevalence process. No? Okay? Same pattern of diseases, no? But to decide which one should be the first diagnosis, you use prevalence, no? Okay? Okay. A comment here, somebody mentioned about sudden increase in size. Ikaw ba, Ann?
Yes po, sir.
Okay. Yung sudden increase, may comment lang dyan, no? Yung cancer naman, unless it's anaplastic, pero anaplastic, it will take some time, hindi siya sudden increase, no? Okay. When sudden increase, usually, ano pa yan, benign pa rin siya, no? So, it's not being said in the book, so, but it's from experience. You have development of colloid cysts, too big, no? Lalaki kagad yan. Parang pigsa yan, no? Yung pigsa is actually the fastest growing mass compared to CA. Di ba? Yung pigsa, di ba? Biglang laki yun. Tama? Okay. Ganun din sa thyroid, yung colloid cyst or even sa breast mass, no? Pag biglang laki, no, at masakit, no, usually cyst yun, no? Accumulation of fluid, no? So take note of this, yung when you use sudden increase in size, no? Okay. Or sudden increase in a matter of 2 months, 3 months, pwede pa, di ba? Okay. So, okay. Ikaw rin ba nagsabi ng frequency of CA? Ann?
Yes po, sir. Parang yung reference ko po is up to date po, sir. So, more US data po siguro. Yun po, around 4 to 6.5% po yung stinate sa article po.
Okay. Sige. But yung mention mong ordering of the CA, papillary, follicular, anaplastic, medullary. So, papillary is still the most common. Follicular, number 2. Number 3, in the Philippines, it's anaplastic, I guess. Medullary is not so common. Okay. Sa US, mas common yung medullary, other states, okay. So, but this is based on experience. Wala tayong masyadong data, okay. From experience, medullary is the rarest among the 4, okay. Yung anaplastic is more common than medullary. So going to the paraclinical diagnostic procedure, okay. Okay, you put there 60% versus 40% degree of uncertainty. So how do you you will ask me, how do you determine the degree of certainty? Na? Kaya ang tanong mo, kasi hindi ginagawa ng ibang doktor yan, di ba? Ako lang nag-emphasize na, okay. And in your practice naman, even as interns, no, you have encountered situations that when you come out with decisions, ano kaya ito, anong more likely, anong ano, di ba? Okay. So lahat ng clinicians will have that inner thoughts also, di ba? Okay, but we have to quantify it, no? Hindi pwedeng 50-50, that's another mentality, di ba? Kasi kung I say 50-50, anything goes, and then you end up with shotgun paraclinical diagnostic procedures, no? Kaya maraming test na ginagawa na hindi kailangan, no? Okay? So you have to quantitate it, no? Okay? And then the quantification, again, this will be subjective based on what you read, no? And also your experience, no? Yung experience mo na lang, no? Okay? Walang textbook na magbibigay ng mga data niyan, no? Okay? So as of now, wala pang textbook na ano, no? So as a rule, this is the guide that I use, no? Number one, I give a higher degree of certainty if I base my diagnosis on signs. Signs kasi is more reliable than symptoms, no? Signs, and then complemented or supported by symptoms, and then supported by prevalence, no? Okay? Tatlo yun, di ba? Okay? But if you have definite signs of malignancy, like neck nodes, no? Mas ano yan. So pag may neck nodes ito, you go for malignancy already, di ba? Okay? Kahit na masakit, kahit na ano, di ba? Okay? O kahit na sabihin niya, 1 year lang ito, 2 years lang ito, ganun, no? So, which is part of history, no? So, the role is you can quantitate your degree of certainty, no? Ang more reliable is you have, if you're quite certain, if you base it on your signs, then supported by your symptoms, and then supported by your prevalence. No? How common is that disease, is that diagnosis in the community? No? Now, you're not quite certain as a rule if you base it on symptoms only. Okay? Symptoms. No? Okay. And if you just base it on prevalence, it's also not common, not certain. Example, sabihin natin, somebody asks you over the phone, magko-consult lang ako sa inyo, doktora, doktor. May pasyente ako, may goiter, no? Anong sa palagay mo? No? So you give an opinion, most likely benign yan. Most likely benign yan without any other data, di ba? Okay, so you're giving an answer based on prevalence. No? So okay lang yan if you just tell them it's based on prevalence, but you're not sure, di ba? So you really have to examine the patients, di ba? So that's how you answer these mga telephone calls, telephone referrals, mga friends, no? Okay. So sabihin mo, I'm not sure, but based on prevalence, very common yan. Kaya most likely benign, no? But I still have to examine the patient. Okay. So the other points about certainty is that I use the 90 as the cutoff. No? Most of the tests, when you have, even with ultrasound, no, yung mga CT scan, mga 90% accuracy yan eh. No? Okay, lahat. Ikahon mo na. No? If it's less than 90%, no, ano na yan, mas mababa. You can say it's not certain. No? Okay. Okay. Kung minsan pwede mong itaas based on experience, pwede mong itaas sa 95. No? Ikaw lang mag-estimate doon. No? Nobody can fault you for that. No? Okay, because at the moment there's no data. No? Okay, but you just have to tell the patient, this is what I think is the quantification of the degree of certainty. No? Okay, I might be wrong, sabi mo. No? Okay. But based on that, kasi you will come out with decision whether you will do a paraclinical diagnostic procedure or not. Okay? Ano yung rule doon? Anong rule that, when do you do, what is the indications for paraclinical diagnostic procedures in terms of certainty? Ira. As a rule,
Sir,
Tyra?
sorry po. Ano po yun, sir?
Ano yung rule na that we follow when you go for a diagnostic procedure guided by your degree of certainty on your clinical diagnosis? Yung, nabasa mo
Dapat
yung diagnostic
po
process ko, di ba? Nabasa mo?
yes po, sir.
Hmm.
Dapat po 60-90 po.
60, ano yung 60-90? Naintindihan yung question ko? What is the principle that I gave you in the
Sir,
in that video, say. Total ko nabigay ko yung video sa inyo. It's not
Yes.
unfair naman kasi binigay ko yung video sa inyo, di ba?
Pag greater than 90% po, sir, yung 60-90% po yung certainty, no need na po ng need po ng paraclinical.
No need. Need or no need?
Greater than 90 po, no need na po ng paraclinical.
Okay.
Sorry po.
Okay. Sige. As a rule, if you're quite certain of your diagnosis, you don't need your paraclinical. Tama? Common sense lang yan, di ba? Okay. So, this is not frequently practiced by our colleagues, di ba? By physicians. Na? Isang kibot lang. Parang ritualistic na lang yan ng mga doktor natin ngayon, di ba? Lab exams kagad, di ba? Okay. So, if you have epidermal cyst dito sa kamay na nakita mo may punctum, no? So, may punctum na 98-99% sure ka na, wag mo nang i-biopsy, diretso mo na. No? Gamot, itanggal mo na yung ano, if it has to be removed, it remove na. No? So that's the application there. If you are quite certain of your diagnosis, you don't need your paraclinical, diretso ka na. No? Sabihin mo lang sa pasyente, no? Informed consent. No? Kasi a lot of patients, they are influenced by other doctors because it's rampant. No? Do a lot of tests. Bakit? Lalo na yung mga galing sa abroad, bakit doon sa ginagawa yung mga test bago tanggalin na so you have to advise the patients na then kung talagang gusto niya wala kang magagawa di pagawa mo pero at least you inform her no or him no that as a rule you don't need na pwedeng diretso na no okay so as a rule if you're not quite certain you do a paraclinical no okay. So we say that the guide that I use is that less than 90, it's classified under not certain. No? Okay. More than 90, pwede na, certain ka na. No? Okay. Mas maganda nga kung 98. No? That's why when you do a lab exams, kung may 90% ka, you have to justify it. Say, you want to increase it to 99. Bakit mo i-increase to 99? No? To do a lab exams. Because number one, may special reasons ka. Because that will entail operations, that will entail a massive extirpation of a mass of an operation. No, i-justify mo lang. No, tataasan mo. No, okay, okay. Everybody gets the indications for the paraclinical.
Yes po, sir.
Okay. Okay. So tama yung sinabi niyo, 60% and then you're talking about the nodular non-toxic goiter, no? Most likely it's a nodular colloid nodule, 60% and then CA 40%. So pag nodular non-toxic goiter or colloid adenomatous goiter, usually medical management, no? That's why you need a paraclinical, no? Okay. So as I said, you don't need your TSH, no? Ang next move mo will be your either imaging or histopath, no? Okay, yun nilagay niyo dyan, no? Yun na lang, no? Kasi based on may nodule ka, yung pulse rate mo is normal, you don't need your TSH, thyroid function test, okay? So again, I want to point out, community issues yan, rampant yan, dekahon yan, no? Okay? Kaya napapamahal. I don't know how how successful will be our universal healthcare law. Universal healthcare law is basically funding yan, di ba? Yung mga resources, di ba? Kung yung practice ng mga doctor hindi baguhin, lahat gagawin, mauubos yung pondo, no? Okay? So if you don't need your thyroid function test, you don't need to do it anymore. Yung cost is not 500. Okay, saan mo yung nakuha yung 500? Okay. At TSH lang ito. TSH lang ito, no? Okay. Pwede. 500. Okay. But usually, they count sila lahat. TSH, T4, T3, T4. Di ba? Tatlo, no? So usually, abutin ka na 1,000 plus or 2,000, no? Okay. Okay. So you need a paraclinical diagnostic procedure. You have a choice of thyroid, ultrasound, CT scan, MRI, and then PET scan, and then your histopath. Okay. So when you say benefit, to make it simple, yeah, pwede itong sinasabi mong sensitivity, pero make it simple to the patients, no? Okay. By explaining what are the benefits of the ultrasound, anong ginagawa doon. So sabihin mo, makikita mo yung structure of the bukol, no? Okay. Yung border niya, no? Kung irregular ang border, then you suspect malignancy, no? Then, if it's solid, it's hard to determine whether it's solid or cystic on palpation. So, kung solid siya, it can give us some information, no? Okay. So yung irregularity of the tumor and also the solidity or cystic nature can be seen in CT scan and MRI, no? Yung PET scan, hindi, di ba? By ano yan, function sa PET scan, no? Okay. So how do you choose, no? How do you choose and how do you advise the patient on the three? Thyroid ultrasound, CT scan, MRI, no? Huwag niyo input mo na yung cost, ha? You look at the benefits, mamaya na yung cost. Palaging in that order, benefit, risk, cost, availability, no? Kung ang PET scan has the highest sensitivity, yung CT scan mo has only probably 50, 60 example lang yan, pero pinakamahal, you might go for the PET scan. Okay? Tama? Okay. So ultrasound can give you, as I said, 90% information. As a rule, mabibigyan ka ng mga test, yung mga accepted test, no? So 90% of the time, the ultrasound can give you that information that you want to have, which is what you want to know, whether it's solid or cystic. Number two, the border of the mass, whether it's ill-defined or well-defined, and other added features that might be seen in the ultrasound in terms of the structure, no? CT scan, ganun din. Makikita, mas refined lang, no? Okay? Ng konti, no? Okay. Then, after that, you input kasi kung structure ang kukunin mo, not the functions, huwag ka na mag-PET scan, di ba? Okay. So you go for choice between ultrasound and CT scan or MRI. So between the two, so it says that you have lower sensitivity and specificity than ultrasound. Bakit kaya? Bakit kaya? That we all know that CT scan and MRI has a higher resolution, di ba? Sino ang nag-present ito para clinical?
Jeremy po.
Sige. How do you explain that?
Sir, kasi po yung sa thyroid po, it's po na useful lang po yung CT scan and MRI when there is metastasis na po and extrathyroidal na lesions po. Yun po. Pero sa thyroid itself po, ultrasound po yung mataas yung sensitivity and specificity po.
Yung extent of the disease, extent of the disease, tama.
Sa CT scan and MRI po.
Pero kasi they said that, kasi yung ultrasound makikita niya cystic or solid no? Yun ang pinakamaganda dyan, no? Sa ultrasound, no? It's very important information that you can get, no? From the imaging procedure. Once it's cystic, majority will be benign, no? Okay. Once it's complex also, majority will be benign. Okay? Okay. So usually ultrasound ang pipiliin mo compared to CT scan and PET scan, considering everything. No? When you say risk, yung risk ng ultrasound, wala. Yung sa CT scan, may radiation, di ba? May dye, di ba? Okay. That's what, when you talk about risk, what are the mga side effects of the procedure? No? Okay. PET scan, mga dye, no? Ganon. No? PET may CT scan din yan eh. No? Okay. Then the cost. Okay. Then availability. Okay. Then needle biopsy, it can have a diagnostic accuracy of 97. Okay. Maganda yung batting average ng study na yan. Ha? Okay. Sa akin, pwedeng 90% pwede na. 90% batting average for fine needle, pwede na. But it has to be done properly. No? May magandang technique yan. Eh. No? Okay. So, comparing the imaging and the biopsy, you can tell the patient mas direct ang information that you can get from the needle biopsy compared to the imaging, which is indirect, di ba? Information, no? Okay. Pero but that will entail pain. May konting pain mo na, initial pain, di ba? And pagtusok, di ba? So, then if you need to evaluate the other part of the thyroid, kung may duda ka, then you can use ultrasound muna, no? To guide you, no? Okay? So that's how you make a decision. Kasi in that patient, pwede kang mag-proceed sa needle biopsy without the ultrasound, no? Muna, or you can do the ultrasound first, then the needle biopsy. Okay? But you talk to the patient, no? Tell them what are the advantages, disadvantages, no? And then let him choose. Kung natatakot siya sa needle biopsy, o sige, ultrasound mo na to buy time, no? Okay? Okay. So, yung operations naman, okay, total versus subtotal. Okay, first of all, let me quick questions. Why did they decide to operate the mga residente? Were they suspecting malignancy already?
Sir,
Sir, they were considering malignancy na po. Yun po, nag-commit na po sila na.
Bakit? Anong basis nila? Hemorrhagic syndrome.
On PE daw, on history, PE, and imaging po, sir.
Okay. Hearsay lang. Hearsay. Phil, hearsay lang ito.
Medyo po, sir, pero parang yun po yung sabi ng resident, sir.
Okay, so decision ng surgeon, ha. They have to rationalize it. Bakit sila nag-commit na nag-operahan na lang, no? Okay. So hindi porke tumama sila that will justify it, no? Kung sakaling benign na pwede pa rin gamutin, no? So basta i-justify lang and then tell the patients why operation should be considered, no? So, a reason could be, on physical exam, baka medyo matigas ang suspicion natin, malignant talaga, no? Okay, that can be told to the patient. And number two, sometimes you can say, baka mahirap makuha sa gamot, no? Which is true, no? So, although medicine can be tried, but does not guarantee it will disappear, no? Okay, so especially those which are prominent, no? Then you can justify an operation, no? Even for benign one, okay? Okay, so between total and subtotal, so it's a choice between these two, okay? So after the incision, the surgeon will have to check intra-op, no, pagbukas niya, is it malignant or not before proceeding to a total or subtotal, no? There's another stage there. Hindi porke pre-op, sabi mo, I would suggest total, hindi ganon, no? So tentatively, can be total if it's CA or subtotal. If it's benign, no, intra-op. Nag-frozen section ba sila? Hindi.
No po, sir.
No, no po, sir.
Okay. So, by, sige, patingin yung specimen. Okay. So nakikita niyo itong white, yung white is, ano yan? White tissue. Mukhang solid siya. Do you have a picture of the, nakabukas yung cut specimen? Natakpan eh.
No po, sir. Sorry, wala pong
Wala.
documentation.
Okay.
po, sir.
Ito, pero nakikita niyo yung white element na yan. White na yung sa tumor. Okay? Yung cut surface. Nakita niya?
Yes, sir.
Okay. So, yeah, that's a sign of malignancy already. Papillary CA yan, usually. No? Pag follicular CA, usually fleshy, parang kidney tissue, just like the normal thyroid. No? Medyo pinkish. No? Okay. So, intra-op, they have to make an evaluation kung matigas na matigas o pag kinapa after exposing the thyroid nodule, no? Then they would say, thyroid CA, ito, papillary. No? Okay. So just by examining, they can tell, or I can tell kung they're not experienced, they won't be able to tell. No? Okay. So remove the left thyroid gland muna, and then after that, it depends on the protocol. Kung number one, kung merong mga nodules, pero sa ultrasound may mga nodules sa right side, maliliit lang naman, benign yun, di ba? Okay. Now, based on the protocol, if you have solitary nodule, if it's total, then you do total. If it's based on the protocol, if it's smaller, no, then you can do a subtotal. No? Okay. So ngayon, it's hard to discuss. We won't waste time discussing that. It depends on the protocol. May controversy pa doon. No? Okay. Pwedeng subtotal, pwedeng total. No? Okay. And then, yung mga sinasabing justification, if one side is, if the tumor is located in one side only, the other side is normal, they use they justify the total to do a RAI, to facilitate an RAI, and also to facilitate the thyroglobulin test. For me personally, I don't think, I mean, it's not really necessary. No? Kasi pag tinanggal mo yung the other side, RAI pa rin nila eh. No? So, saka usually yung monitoring naman, you can just use other tests to monitor. No? Okay. Anyway, those are protocols that we have to consider. No? Some would go for total thyroidectomy just to facilitate the monitoring, no? Which is not really a very strong indication. You can do other kinds of monitoring technique, surveillance. No? Okay. And then yung nerve injury, it can also happen on one side, ha? Phil? Okay. Okay, hindi lang sa total, no? Nerve injury can happen on one side. Kung tinamaan kung ito yung tumor nakadikit doon sa recurrent laryngeal nerve, no? Kahit subtotal lang siya, no? Then you can have recurrent nerve injury. No? Okay. Higher incidence ng hypoparathyroidism in total. Kasi andun yung kabilaan eh, no? Yung apat. No? Okay. So you'll be those two pairs of parathyroids will be at risk. Okay. So health restoration, basically counseling, no? Counseling the patients on the prognosis and thank you for summarizing the framework, Nicole. Okay, but okay, let me go direct to the point. Health restoration and maintenance. Basically, kung may symptoms, you try to treat the symptoms, then counseling. Counseling, they will always ask you the cause. What's the cause? Usually you don't know. Tell them you don't exactly know. But you have to provide psychosocial support. Then if it's papillary, you just have to convince them that based on experience, it has a good prognosis. No? Okay. And then they also have to be advised on the surveillance, a lifetime surveillance for possible recurrence, no? And of course, lastly, they have to institute change in the lifestyle, healthy lifestyle, no? As a rule, no? Lifestyle, no? So we don't know the exact cause, but it may have something to do with the healthy lifestyle, no? Okay. So tell them just promote healthy lifestyle, just to avoid any possible complications, not only on the thyroid, but on other parts of the body. Okay. So with that, any questions? Any questions that you want to ask?
Sir,
Uh,
if you were to manage the patient, who would you have done total thyroidectomy din po for the patient?
kung may nakapa akong kabila na yung yung sa nodules sa right side, no, I would do a total, no. Pero kung wala, I might do a subtotal total lobectomy only, no, as long as I have informed consent. I know that pag mag-recur siya, pwede siya mag-recur on the remaining, no. But in terms of long-term prognosis, no, yung survival, pareho lang, whether total or subtotal, no? Okay, that's my experience, no? And then, kasi kung mag-recur on the other side, even on the neck, sometimes on the neck nodes, then a lot of times you reoperate, no? And it will not change the prognosis. Habulin mo lang, no? Okay. Okay. Hahabulin mo lang. Let's say nag-recur siya on the right side, then ma-diagnose kagad, then tanggalin ulit, no? Or kung may neck node siya, tanggalin, no? Okay. So that will yung problema lang, there will be, you cannot predict, no? You'll have another operation, no? Pero sometimes there won't be any recurrence. I-monitor mo lang. Then ibabangga mo na lang kasi yung sa high incidence ng hypothyroidism. Yung recurrent nerve medyo madali i-preserve yun eh. Basta maingat lang yung surgeon, no? Okay, it's the parathyroid, medyo mahirap kasi maliit lang siya eh, no? Okay. Okay. And then once you have hypothyroidism, usually sana transient lang, kung permanent na lifetime calcium intake na yon, di ba? Okay. Okay, did I answer your question?
Yes po, sir. Thank you po.
Okay. Any other questions?
Sir, in practice po ba, parang rene-refer lang po ba sa endo yung patient pag hyper or hypothyroid po siya? Kapag po ba parang euthyroid, hindi na po ba need na referral or refer din po, sir?
Okay. In practice, I thought, iba yung practice natin yan. Okay. Ako, my practice is I treat the patient as a whole, no? Okay. Kung euthyroid, I don't refer, no? Euthyroid, normal, normal, no? Just check up, no? Kung euthyroid na may nodule, na may mass, no? I go for a medical suppressive therapy, no? Okay, then I monitor this patient, no? And then for hyperthyroidism, I only refer patients to endo or even nuclear medicine if I need radioactive iodine therapy, no? Kung hyper, no? Okay. And then, kung medical lang, ginagamot ko na, no? Okay. So, but there are a lot of surgeons who rely on endo. Basta opera lang silang opera, after that, balik sa endo, no? Okay. Okay. And kasi kumisan, kasi may differing opinions. I have encountered a lot of patients who were referred to me by endo or given to me by endo asking me to operate, no, on what I think is benign, no. So I usually don't operate. Then tell the patients that we just observe, no. Okay. Ganun. Kasi they believe on the Thyroid 4 eh. Maraming may Thyroid 4 ngayon, no. Isang kibot lang may Thyroid 4, pinapa-opera na nila, no. Okay. So beware of the Thyroid 4. Magiging parang sa breast yan, nung lumabas yung breast ultrasound with maraming Thyroid 4, no? Thyroid 4 means suspicious for malignancy, di ba? Okay. So pag may ganon, opera na ng breast surgeons yan, no? So, but a lot of times I usually ask the patient to have it repeated, in another institutions at lumalabas nagiging Thyroid 3, no? So there are a lot of subjectivity in the ultrasound, no? So ganun din sa thyroid, no? Lalo na ngayon, na parang learning curve nila yun, no? So thyroid 4, you just ask for a repeat or just base it on your clinical evaluation. Kung multiple nodules, malamang benign yan, no? Okay, kung walang signs of malignancy. Anyway, kung sa thyroid naman, kung cancer, kung nagkamali isang let's say like me, nagkamali ako sa diagnosis ko, no, very slow growing naman yung mga papillary CA na yan, no? You can still run after them, no? I-monitor mo lang, no? Okay. Okay, any more questions? Any more?
Sorry, last question lang po dun sa how you practice yung determining the degree of certainty.
Okay.
Is it more based on parang studies po ba or more on personal experience niyo po, sir?
Okay. So if you have data, established data, no, yung degree of certainty of the diagnosis, di ba? Okay. There are some who would, there'll be some published data, pero konti lang, no? Then after that, you base it on your experience na. Okay. Huwag mong bibigyan ng 50-50. Okay. Base it on your experience, but honestly tell the patient based on your experience. No? Okay. Okay. I call it subjective probability. Subjective. I've been looking for those data. Wala eh. Hindi ko makakita. No? So I came out with the term of subjective probability. You know, pwede mangyari yon, na? Acceptable. Okay, any more? If there are no more questions, what time is it? We went beyond 12:30. Okay. Okay lang? We went beyond 12:30. Okay. So I'll give you the okay, take a look at your chat box. That's the link. Can you click on it whether you can access it? Chat box.
Na-access naman po,
No.
sir.
Okay. So, yan ang olete. You just answer it, objective type. Medyo marami lang. It's a amplification of the patient management process, no? Which I honestly think you'll find it useful in your medical practice. No? Okay. So, sagot lang. If you get the perfect score, even after 3 tries, 2 tries, 4 tries, no? I'll give you a certificate of completion. And then with some bonus points for your grades. Now, syempre, you have to agree with me, hindi perfect yung presentation ninyo, di ba? Okay, but I gave you that video to read for 4 days, di ba? Okay, but I'll give you bonus points, na? Okay, if you passed it, na? Okay, is that the shared agreement?
Yes po, sir. Sir, we want to ask lang po if when this is due.
As soon as
Sir, sorry, we have
possible.
interns
Kailan ba
and
kayo?
post.
Tapos na kayo last
May mga ward posts po, sir.
Kayo, okay. When do you want to have it? Kayo mag-suggest.
Within the day po, sir.
Ha?
Ward interns are on duty until 7 p.m. po, sir. Siguro 8 po, sir, if that's okay.
Oo, pwede. Today? Pwede. Sige.
Yes.
Oo,
Yes po.
mas maganda para I can issue out your grades already. Okay?
Okay po, sir.
Sige. Okay, so let's have a group picture taking before we leave.
Okay, I'll take the screenshot po.
Sandali.
Okay po.
Sandali. Screenshot. Okay, ready? Sandali. 1, 2. Okay. Okay. Sige. If you have any questions, yes, you can friend me in my Facebook or you can channel your questions to Nicole. No? Okay. Nicole is in my Viber naman. No? Okay. Bye-bye.
Yes po, sir. Sir, thank you so much po, sir.
Bye-bye.
Thank you very much po, sir.
Thank you po.